are opening now new ICU, and they are receiving many patients at the last week, and they are waiting actually for your contribution with them in the COVID-19. Before I will start, we are formulating this course for non-ICU physicians to give them 3 domains in the course. Also, again, before I will go to the content of the course, I would just like to introduce the faculty of the course. We have 2 very active co-directors, Dr. Ahmed Kohel, the one always with us over the last 3 months with all technical zooming, designing surveys, pre and post and MCQs. He's Dr. Ahmed, associate consultant in critical care department in King Saud Medical City. And Dr. Agul Takin, she's co-director, and she's associate consultant also, and she's responsible for all scientific material as well as MCQ at the end of the course. And the 2 diamonds, highly active plus coordinators responsible for all administrative part, Ms. Christina and Ms. Emiliana. As well as the faculty of the course, I will go through each one of them during presenting the contents. As I told, your presence in the upcoming days is very important, and it may be very close. You will deploy it, one of the department of the either internal medicine floor for the COVID-19 patients, or ER, or mostly in the ICU for the new ICU opened in the Iman Hospital. I think 25 beds, and they have now almost maybe 90% occupancy rate there. This course actually is just introduction for the 3 domains. The first one, which is the most important one in the domain, the content, is the safety. Your safety during dealing with COVID-19 patients. Most of our lectures, most of our contents touching the how to protect yourself, either as a general or during the procedure, especially the authorization procedure, or during dealing with the patient with anyone. And you will notice you can abort or skip some of the essentials of the critical care management for such case, because it is not safe to do it now. Even sometimes you will not initiate CPR for a patient who's arrested in front of you because you are not wearing PPE. So safety, it is one from the most important domain in the course. The second one, and many lectures touching this topic. The second one, the COVID-19 itself, how it looks like, the definition, the triaging, the suspected cases, confirmed cases, the management of the patient COVID-19, pathophysiology of the COVID-19, and this is another domain. The third domain, we're touching some essentials of the critical care. Of course, you have different subspecialties. Maybe you are connected to the ICU, or maybe you are not connected, you're a little bit far. But the good thing, and I can convey the feedback currently from most of the specialists working with us in ICU, even I can say that dermatologists, the OB-GYN, which is a little bit far away from the ICU, really they are doing a very great job with us. We're relying on them. I cannot say 80%. If I'm saying 80%, I'm not actually I'm giving them their values inside ICU. So your presence is very essential with us in ICU. So we are touching some of the essentials of critical care, like shock, like ABG, like mechanical ventilations. Over the upcoming 2-3 nights, we'll go through some of the content. First, we'll go with introduction with Dr. Shahzad, case definition and pathway with Dr. Shahzad after just my introduction. I will go before Dr. Tasmaya. I will go through quick guide and the protocol of the COVID-19. Then Dr. Tasmaya will present infection control principle. Dr. Agul Takin, she's in call today, so tomorrow she will present the ABG. Today, Dr. Ahmed Kohel will present the shock. Dr. Waqqas, ICU consultant, he will present the COVID-19 pathophysiology, because it's very essential and we have many different pathophysiologies. Tomorrow, inshallah, Dr. Agul Takin will present the ABG instead of Dr. Ahmed Kohel. Dr. Basim will present essential of mechanical ventilation, his ICU consultant, as well as Dr. Omar Ramadan also. He will present, I think Dr. Ahmed Kohel will present the ARDS in COVID-19 patient. Dr. Bashir Abdurrahman, very important lecture about the pharmacotherapy of COVID-19, all medications related to the COVID-19. Last day of Wednesday, Dr. Ahmed Al-Balshi, our ICU consultant, will present pneumonia. Dr. Saima, she will present CPR dynamics in COVID-19. She's the head of CPR team in the King Saud Medical City ICU. And the very important lecture will be like a video simulation, which is a COVID-19 intubation airway management. Very, very important and very essential topic. It will be like video. As you have noticed, and we'll close by the end with open discussion, and then with MCQ on Wednesday, almost at 10:30 p.m. As you had noticed, we not rely only the course. We have different materials. We posted in the group some online free courses by SCM and by the Prince and by the Muhammad bin Rashid University for safety. This is a free course online, and we found those very essential and very valuable to go through each one of them. Another materials like videos, like airway, like triaging, like CPR, like intubation, we also posted in the group. So either the video going on with you, you can see at any time, or these online courses, or the lecture will be recorded by Dr. Ahmed Bouhail actually, and we will post it in the group after we'll finish the day. Then we'll end with MCQ. After that, what will happen? The very common question for each one of you. After finishing the course, the certificate will be released based your attendance in the course, the lectures, as well as we are monitoring your attendance per minutes, how many minutes you attend per day, as well as the result of the MCQ. You release the certificate that you did pass the course. When you will join the ICU, we'll do like bedside orientation of the most of the hands-on, like airway, like infection control, like orientation of the file of the protocols. Later on, once you will join ICU, this is the clinical part of the course. I hope you will enjoy. I hope you will get benefit, and I hope also you will be compliant with our timing and with our course, with our materials, and as well as we'll see you soon, inshallah, on ICU. Right? Thank you so much for being with us and managing this crisis. And I hope, inshallah, we are close to the end, and I hope we will not have another peak. So, for any queries, you can write in the chat room, and if not, we can proceed at any time. The WhatsApp is open, the chat room is open. You can ask any question at any time. I would like to thank the head of the postgrad of the Liban Hospital, actually, Dr. Noha Al-Jaber. She's did a very great job with us, as well as, of course, the cluster leader, to have you during these upcoming 3 days. Thank you so much. And we can go if you don't have any queries for the administrative part. For any scientific part, let us have in each lecture, post lecture, we have specific time for the question for each lecture. Dr. Shahzad is around. I can. Hello, Assalamu alaikum, Dr. Shahzad. Ahmad is not yet joined. If not yet, I can proceed for my lecture. Bouhail, you are with us. I cannot see him in the participants. Okay. To save time, I can proceed for my lecture until Dr. Shahzad will join us. Let me go to I will share my screen again with my lecture. Will join, he will present Sorry, I lost my connection for a minute. Dr. Dalia, Dr. Manal, they are raising their hands. Do you have any question relating? Yes, the quality is poor. I hope now this already it was disconnected. I hope now it's okay. Is it okay now?
Yes, Dr. Mad, yes.
There is Dr. Dalia. She's raising her hand. Do you have any queries, Dr. Dalia? You can write in the chat or you can unmute if you like to talk. Or Dr. Manal also. If you have any queries, you can write in the chat. They are raising their hands. Okay. Okay, we will proceed. Because I think Dr. Shazad not yet. Dr. Adela connection. Okay, thank you, Doctor. You can see the screen.
Dr. Mad, can you make it
no.
full screen?
Hello, Ahmed.
Can you make it full screen?
I did it. Already full screen.
Yeah, now it's okay.
I did it. خلاص, okay. Assalamu alaikum. As I have started, actually, we have support to start with the definition, the suspicious, how to do with the virus, with Dr. Shazad. I think once he will join, because he's all of us in call today, by the way, I will finish my lecture and I will go to the hospital also. I will go through briefly the outline of the COVID-19 in critical care patients. As we have mentioned, as all of us know, COVID-19 viruses, it is some from the SARS-CoV virus. It is causing severe acute receptors. As I'm telling, this is a quick guideline. This will be specific lecture. As I told you earlier in the introduction, we have two big domains in the management of the COVID-19, clinical management as well as safety. And both of them, if you're comparing which one is more important, for my opinion, both of them are very important than each other. And as I told, need quality factors. I will go slowly. I hope it can be okay. Safety as well as clinical management. For my patients, clinical management, I need to do, for example, procedure. Now I have to do, no. You have to consider in the COVID-19 patient before we proceed the safety of the health care worker staff before going with the procedure. For example, you cannot go with a simple, any bronchoscope for COVID patient unless life-saving. You cannot start CPR unless it is safe. So many complications, many interventions you have to hold or think about it before you are going with this is because of the safety. Usually, most of the COVID-19 patients have mild symptoms. So this, alhamdulillah, is very good. But the admission of the ICU usually coming due to hypoxemic respiratory failure, the most common infection. It has to be rapidly progressive, especially in the early era when you have in the May and June, it was disaster. Most of the patients coming within 24 hours, they need intubation and they will very so much after intubation. From the beginning of symptoms, it takes around 10 days for the patient to have the prognostication factor of the COVID-19 about how to know this patient will be severe. We have three major factors. Demographic factor, most of the elder people, so most of them die, it is high, but between 50 and 40 years, So the as I told, there is geographical bad connection again. The geographic distribution or the demographic distribution is different from different place to other. We have less old age, and fortunately, we have some of the old age they covered just 2 days back. We have one patient 94 years old, already discharged from ICU. She was in ICU, she was vented, extubated, she's doing well, which is not common sense for most of the COVID patients. LDH and
Madi. Sorry for the interruption, just for a while, and we'll resume it back.
كده اوكي؟ خلاص احسن برضه. خلاص ستوب فيديو. يلا اوكي ثانك يو. طيب the comorbidity, as we have mentioned earlier, the most common comorbidity here is diabetes and the bronchial asthma, as well as the cardiovascular disease. The lab findings, we have many lab biomarkers. We are saying these are biomarkers. The early one is lymphopenia, D-dimerizing, troponin, ferritin, C-reactive protein, and the LDH, and we are monitoring them daily. If you go through the comorbidity worldwide, in the China and America, cardiovascular was the highest, but we are here in our community, diabetes is the highest comorbidity we have. Look to this age distribution worldwide in the USA. Many cases you can find this blue column showing how the age distribution of the COVID-19 patient, the highest peak between 20 and 24 and 44 years. The second peak, which is 65 to 84 years. What we have here in our epidemiological distributions, most of them between 50 and 40 years, and we have through 2 studies published for demographic distribution of Saudi Arabia, and we still our cluster paper for publication for demographic data and epidemiological data, it is under press. So we did notice most of them in the middle age group between 40 and 50 years old. But the good thing, if you look at the fatality rate, case fatality rate, this is the orange color here line going on. Usually in the middle age group, it is very low, reaching 2 to 1%. It is very high with the patient with the elder age. So the case fatality rate is correlated well with the age group. So more elder patients more likely to die and become more severe, especially above 85 years, age 20%. This is a very good scheme and very common scheme for this explanation, the COVID-19, how it looks like. If you look to these graphs, the blue triangle here, this is the viral response phase. And once the virus invading the body, of course, we have a response from the patient. This is host inflammatory response in orange color. First, the viral response phase will be very high, then it will go low, and it can simply disappear when you have a good response, inflammatory response from the patient. But if the inflammatory response is poor and the patient going cytokine storm, so the patient will go the multiple organ injury or multi-organ dysfunction. So simply, if you are classifying all management of the COVID-19 patient, whatever the presentation, the symptoms, the investigations, based on this pathophysiological mechanisms, we can find early phase, which is almost the viral still invading the body, we still have the viral response, we have the mild symptoms, and in the middle phase, second phase, either you can find 3 phases, 4 phases, or even 5 phases in some diagrams. This is the correlation between the overlapping between the host response and the beginning of the host response, usually coming with those patients with pneumonia. Later stage, the patient coming with the multi-organ failure. And if we go through in details one by one, as I told you, either it can be in some books saying 4 stage, some saying 5 stage, but this is the easiest one. It almost have the same principle. Asymptomatic in the incubation period. In the prodromal stage, we have almost 5 days with symptomatic but no evidence of pneumonia. Pneumonia phase, we can find patient with pneumonia without hypoxemia, and you can find patient with hypoxemia with X-ray change and radiological findings. The last one, which is embryological, this is the most dangerous phase and risky phase, depending on how is the host response, how the inflammatory process of the patients. This one can go with the multi-organ failure. So this is the stages. And as you can see it here, likely most of the patients are mildly, only 15%, which is orange one, coming to severe. Severe, it means he start to have oxygen requirements and he's needing high oxygen requirement. Or critical patient, which is almost 5%. Those are the patient between severe and critical. Those are the patients you will see in the hospital. Another you will not see inside the hospital. If you go to the symptoms or clinical signs, usually in the incubation period, even PCR positive, you will not find any symptoms of the patient. And fortunately, currently, alhamdulillah, I think the symptoms, even in the stage of the prodromal stage, it is less. Even in the pneumonia phase, it has become more less nowadays. We have many cases passing very smoothly without just positive PCR and some small fever, myalgia, mild diarrhea, or arthralgia, sore throat, and the cough. Those are the patients in the prodromal stage. If going to hypoxemia here, shortness of breath, increasing the biomarkers, as you can see it here, increasing the oxygen consumption, this is the stage, severe cases in this stage. Critical patient or critical case, patient coming with multi-organ failure. Of course, the COVID is the causing factor, but still we have another system affected, either direct affection by the virus itself, which will go through the pathophysiology. It can be affect the heart, can be affect the pancreas, that can affect the brain, coming with a severe, or a reflection or the side or the response of the body, like acute kidney injury, like septic shock, like secondary infection. So this is the most critical phase at the end, and the most of our ICU patient coming. So organ failure, usually hypoxemic respiratory failure is the main cause. Shock, acute kidney injury, 20 to 30% of them. If you go through the blood, you will find just mild acidosis because of pneumonia. You will find some CKs rising. Lymphopenia is a very good factor. Elevated CD-active protein, D-dimer 13 and LDH, we are monitoring them daily. Thrombocytopenia in mild, not common. It is present, but not common with such patient. LFT slightly rising, and very evident. Most of the diabetic patients, we cannot control their DM. Very difficult to control their RBS of the COVID-19 patient. Lymphopenia, as I have mentioned earlier, one from the most important prognostication factor. Usually those patients coming early with low lymphocytic count, less than 0.8, and more patients will die with more lymphocytic count low. If you look to these graphs, you can find this blue color, the patient who survived. You can see lymphocytic count is higher than those who died. This is yellow color graph. And with more lymphocytic count, more likely patient will be severe, and more likely patient will be die. So if we go through prognostication, D-dimer, one from the essential. And I think now all people, even the public people, they are read about the COVID-19 and they know well how the pathophysiology, how it's working. But D-dimer is a very strong predictor, but also correlated with the mortality. It means, it is true statement. It means higher D-dimer, more likely patient will die. Look at here. If you have the patient, this is the blue color line of this study. You can see it here. D-dimer not exceeding 1 in most of the days here. Usually starting on day 4, but those patients in red color graph here, more patient, more D-dimer, more patient will die. We found D-dimer actually more than 48, 50, 80 even in some cases. D-dimer going very high, more likely patient will die. This is statistical analysis, and the most of the studies showing, even with the after adjusting for another confounder or another bias by statistics, whatever multivariable or univariable odds ratio, very high patient likely will die, significantly high with D-dimer. So we are focusing on D-dimer, and we are going with the management based on the D-dimer to anticoagulate the patient. Pathophysiology, Dr. Dr. Waqasi will present it in details, many pathophysiological, many viral application, direct invasion of ACE2 receptors in the liver, in the lung, in the epididymis, in the pancreas, as well as in the brain. And the last one of them, which is cytokine storm. Most mortality in this phase with cytokine storm with high cytokines markers. I will just give this example to show you something very important. This is, for example, one in ER doctor, right? He's intubating his pharyngeal PCR on the first day, it came negative. But after 7 days, he developed fever. He was intubating confirmed case. This is a typical X-ray picture for the patient with COVID-19. Second sample he took from himself, of course admitted, he has pneumonia. The second sample taken, it came also negative. This one was starting on the old regimen of the patient with COVID-19, which is they were treating him by hydroxychloroquine as well as azithromycin and ceftriaxone. So, second sample after 7 days for this doctor came negative again. So if you have a patient or you have a healthcare worker, if you have a physician, first sample negative, he has showing complete picture, radiological, clinical, lab investigation of the COVID-19 patient. You treat him as a COVID-19 patient. After 7 days, you start to swab him again. It came negative again for nasopharyngeal swab. So in this stage, the question on this stage, after 7 days, what you will do? You will treat him, look at the first one or two. First one or two, khalas, you will almost exclude the COVID-19. You stopped hydroxychloroquine and azithromycin and to continue as community-acquired pneumonia. You stopped hydroxychloroquine and started tazocine instead of ceftriaxone because of severe pneumonia. So this is number one and number two. Number three and number four, still you have a belief this patient is COVID, but you are not believing in the PCR. So you will do bronchoalveolar lavage. We have Paul, mashallah, Dr. Ahmad, he gave it us. So you will do another PCR from the bronchoscope, or you will repeat again from the tracheal aspirate, not bronchoalveolar lavage. So which one you would like to go through? 1, 2, 3, or 4? You can just vote on this poll. Start voting, please. Yes. Great. Now we have almost 30% of the attendees. We still want more, please. If you are writing in the chat room, okay, Dr. Heba, Dr. Mona, 4. I will consider it. I wait for 10 seconds more. Please, more response. Either in the chat room or in the polls. Khalas done 1 minute, okay. So let us say now, if you can see it here, most of the attendees, they are dealing with it as a COVID pneumonia, but we have equal between 3 and 4, right? Between 3 and 4. Okay, so let us say the one who mentioned 3, he will go through bronchoalveolar lavage because it's more sensitive. Agree for that. The one who said for 4, number 4, 3. Number 4, the one who will make it try it. So he will not go with bronchoalveolar lavage, but he will repeat again tracheal aspirate. If you are going with the clinical management, I will go for bronchoalveolar lavage. I will do bronchoscope, I will take sample. But if we have mentioned early, the safety, as I told you, safety can affect your intervention, right? So because of safety, even high sensitivity, as you can see in this table of PAL, 93% for detecting the virus, but I will not go through. I will not disconnect the ventilator. I will not pass the bronchoscope inside the ATT. I will not expose the healthcare worker for the aerosolizations during procedures to just prove I have a clinical, I have a lab benefit. I will consider the PCR first sample and next sample either poor sensitivity or negative or false negative. Nasal swab is 63% of such cases, of more cases. Pharyngeal swab is 32%. So I will repeat the tracheal aspirate. I will not go for BAL for safety of the healthcare worker, right? So I want to say your safety, again, one from the important point, even can interfere with your clinical management. The management, of course, in details, I will not go through. because we have a specific lecture, very nice lecture for the management of the pharmacology, but mainly in the mild phases, just close observation, isolation, tracing of the contacts, symptomatic management, multivitamins, right? If you go to the pneumonia, you need to go start antiviral. It is nothing a must. Nothing is COVID-19 definitive, right? Antiviral, steroids, anticoagulations. If you go to severe cases with this cytokine storm, you need to defeat this cytokine storm, whatever you like, steroids or tocilizumab or whatever the modalities like plasmapheresis, IVIG, whatever you like. So if you categorized the pharmacotherapy with mild case, isolation, tracing, supportive care, mild, moderate to severe, it will be like anticoagulations and antiviral, as well as steroids. Last stage, we'll go through the interleukin 6. Nice scheme to can tell you those green colored the viremia, the viral replication, the viral root. This purple one, the inflammatory response, is still with the beginning of the early phase inflammatory response, we still have low. We don't have viremia going higher, saturation accepted in the antibody. We don't have problem with saturation, the red color. Right? Once we have inflammatory markers going higher, this is the beginning of hyperinflammatory stage. Even viremia will go down. This is the early stage of the intubation, hypoxemia. This is the green color. In this stage, you need to awake proning, fluid management, heparin administration, low-dose steroids, avoid intubation as much as you can. If the patient continually deteriorated, reach saturation low despite option therapy, those patients, they need salvage or rescue therapy with extensive management for cytokine storms and invasive management for the option therapy. Nothing approved by FDA, but I will not disclose this statement. I will keep it for Dr. Bashir to give you the clue for whatever you have is new. And supportive management is the most important one. Management of the fever, management of hypoxemia, management of septic shock, arrhythmia, cardiomyopathy, and the other problem like acute kidney injury, whatever. Many guidelines. Guidelines in survival sepsis campaign, guideline in the American guidelines, Australian guidelines, Canadian guidelines. Alhamdulillah, the Saudi guidelines, we are not away, we are in close to the international guidelines. And I can disclose even the international guidelines, there is almost all international guidelines, there's a member from Saudi Arabia joining the guidelines internationally. Even the surviving sepsis campaign guideline, the first author, Dr. Adil Hassan, he's Saudi guy, epidemiologist, researcher in Canada, working in McMaster, right? Canadian guideline, they are joining with him, Dr. Yassine Arabi, Ziad Nemish. Everyone, any guidelines, Saudi is a part of the guidelines. We have our own guidelines, we have our MOH guideline, we have our cluster guidelines. And the meaning of the cluster guideline, we did it early, MOH relying on and published in the MOH. As I told, this is our cluster guideline. We did it in SMC and already present in the MOH. They receive it. We are a part of the committee of the MOH guidelines. So this is the ventilation guideline, pneumonia. I will not go in details because it will be touched in the ARDS and treatment of hypoxemia as well as pneumonia. You will find it in your group. I will post. And during your work in the ICU, you will find it in the protocols. Ventilation protocol, awake proning protocol, and even we have some sort of a chart like order set. Instead of writing everything, just a check here. You will find it also in the files. What initial lab you want to do, what the initial assessment, what is the daily lab you want. Just to check this paper, you will find it in the your protocol. Even I will post some of the fatwa present related to the COVID-19 and healthcare workers. As you can see, even we try to minimize those. And I advise you in every center over the last 3 months, 6 months, we're minimizing the paperwork as much as we can. And I'd like to thank actually our Dr. Omar, Physician Affairs Department head. They make some even medical report, it is ready made, just will fill it, as well as even medication sheet printed out with the number. And I like to post this one. This is a summarized of our protocol and MOH protocol. If not clear, I can share it. Thank you. I just will go to this protocol and briefly. Ahmad, you can share it from your side because I think Thank you so much. This is my lecture, but I'll just show you our summarized of the protocol of the patient with COVID-19. I made it and reviewed by our pulmonologist, ID, clinical pharmacist, and my colleagues in the ICU. Already approved, and we are planning. It is updated, and until Ahmed will share. If you look at here, actually, and up, you will find the timelines. Usually, every stage taking from 5 to 7 days. As you can see here, 3 stages. This is the gray color. After that, if you go to the, okay, make it bigger, Ahmed, to be clear. This is the one. If you go, this is the viral response, as we have mentioned earlier, as well as the host immune response, the blue color. Then signs and symptoms in green color, the first stage, second stage, mild, moderate, severe, and critical. This is the stages. Lab investigations, as we have mentioned earlier also, mild, normal routine lab, moderate, mild lymphopenia with increasing prothrombopathy and fertile and edema and LDH, moderate, severe, and critical patients. Lung ultrasound and CT, one from the good models, actually, because it's non-invasive, not aerosolization, you can do it easily. We are not moving our patient for CT, but we can do bedside ultrasound. We can diagnose localized B-line in mild cases. It can be extensive B-line in moderate to severe cases, and as some sort of subpleural and alveolar consolidation. This is in late stage in cytokine storms. The CT finding also is conclusive for the diagnosis as well as prognosis, but we are not routinely shifting the patient to avoid the aerosolization. This one is the respiratory support. As you can see it here, we are starting with nasal cannula from the mild to moderate cases, 4 to 6 liters per minute. We are preferring to go to the non-rebreather mask, 10 to 15 liters per minute. Awake proning, one from the very good modalities, very good outcome. High flow nasal cannula, we can use it with 50, 60 even liter per minute. Awake proning, even with high flow, and the CPAP helmet, one from the good modalities, which is decreasing aerosolizations. We have it now in all cluster group. This is we are using in the moderate to severe cases. If this non-invasive management fail, we can go to the invasive mechanical ventilation, even proning with mechanical ventilation invasive. Look at this one, proning for 16 hours, one from the good modalities. ECMO, I cannot say unlikely to go, but we have some cases for ECMO because of crisis and using resources. We are minimizing the ECMO because of crisis. You don't need to go for the facility or the modality which can consuming a lot of resources and a lot of time. So ECMO, not like MERS-CoV, the circumstances was less than that. So we have many patients with ECMO, but here in COVID-19, very little cases going with ECMO. Pharmacotherapy here, this is just the diagram. Dr. Bashir will present it. Paracetamol, for example, you can start from day 1 until the end. The antiviral medication, whatever, triple therapy, favipiravir, remdesivir, you have the timing to end and to start. Chloroquine, I'm not believing in it, and I think will be supposed to be out of the. It is now in the mild cases in Saudi Arabia, but some centers, some countries, they remove it. Azithromycin, low molecular weight heparin, unfractionated heparin, steroids, whatever the type of the steroids from oxygen therapy patient until the end. Tocilizumab, convalescent plasma, plasma exchange. This is the modality, and these are showing when you can start and when you can end. If you will go down, you will find some guides, reference for the dose of each drug of those. So this summarized of all protocol of the management of the COVID-19 patient with the COVID-19. So by the end of this, I'd like to thank you for attending with us, and I'd like actually to receive if you have any queries, any question. So you are greatly welcome. You can ask in the chat room. Chat. We have 2-3 minutes for questions if you have any queries. As I told, welcome. Dr. Shahzad, mashallah. ايه ده؟ Who's posting Dr. Ashraf Tayyar? Ahmed. Ahmed Ori will desktop will be showing us now to us. Dr. Mona, plasma exchange from early stage. That's a question or statement, Dr. Mona? I can tell you, since beginning of the COVID-19, we start plasma exchange in Imam Abdurrahman Al-Faisal, and successfully we extubate some patient on plasma exchange. After the huge cases we have in King's Old Medical City, we started plasma exchange, but unfortunately, the plasma exchange, it started either late stage or at proper time. So by the way, we are studying, we have our paper, we are processing for the all cases because we're reporting all the cases. The outcome because of improper use of the plasma exchange, as you have mentioned now, early will be better with biomarkers. We're showing that the biomarkers increasing a lot or decreasing a lot with the plasma exchange. But if you start late, if the patient develops septic shock, bacterial pneumonia, unfortunately, it doesn't show outcome. So we can wait until we're studying in details all our cases. But if I recommend the plasma exchange, and Dr. Rodat is the master, and our Dr. Fahd also from Abdurrahman Al Faisal, I'd like to be earlier with the patient with high biomarkers, with the patients not late stage, not cytokine storm. We have another, what is the role of the colchicine? Is not mentioned in the treatment. Yes, Dr. Shahzad, it's just a trial. It's not in the protocol or didn't have promising results. Colchicine, they're using it out of ICU in some cases, in some guide. Dr. Faisal, our CMO, he's trying actually for the protocol to proceed for the study for that one. We're not using it outside our ICU. And I don't have, there is some studies, but for mild to moderate cases, as I know. And you can add, Dr. Shahzad, I know you have an answer for the question, you can add once I will present you now. Dr. Dalia, what about plasma from COVID-19 patient? Yes. We have a list of the donors already. We have some cases, I can say few cases actually, we are processing now. Either our own cluster, we have our own study, or we are sharing the national project of the plasma or convalescent plasma transfusion for patients for the national project submitted by some people from the MAM University, King Fahd University from the MAM. We are a part of that one. I can mention one of our colleagues is a senior consultant in orthopedics. He received the convalescent plasma, all his biomarkers improving, all his requirements improving, but I cannot say, I cannot disclose. Unfortunately, we did find he developed, but not from the plasma, but he has MCA infarction, so we cannot assess. But currently, we are going on some patient with plasma, with convalescent plasma, and I feel it is more promising than plasma exchange. High flow nasal cannula, how much maximum can be delivered oxygen? High flow nasal cannula, you have two things. This is the principle. You are giving oxygen with very high flow, reaching to 1 liter per minute. But in COVID-19 patients, we are not exceeding the 60 liter per minute. With FiO2 100% can reach it. You are adjusting the FiO2, you are adjusting the humidity. So the high flow not exceeding, by the way, RT will not exceed 40, but the temperature you can reach to the 50 and 60. FiO2 can reach 100%. In Egypt, who took it diet? Which one, Dr. Dalia? Dalia, you talk about convalescent plasma. We cannot assess now, Dr. Antik. Cardiomyopathy is reversible. COVID, different actually. Can we start steroids, the early steroids for the patient, which is recovery study showing? Let us say, I will not say all data about it because in the pharmacotherapy we will consider it, but the patient requiring oxygen therapy, he can benefit from the steroids. What about the steroids? I will keep it for Dr. Bashir in his lectures. Had you seen patient with very mild symptoms treated after 7 days or more after the initial presentations? I feel it is a personal question, but yes, we can find, but not significantly. The patient deteriorating usually, but after second, you see, we have almost decided 5 to 7 days each stage. For mild case, 5 to 7 days, moderate to severe, 5 to 7 days, severe 5 to 7 days. So collectively, almost within 2 weeks to 3 weeks, all the stage from beginning until the end. So some patient can stay requiring for 5 to 7 days, very mild or mild cases, he can collapse it late. And even not because of pathophysiology only hypoxemic battle failure, maybe the pathophysiology again, which is microthrombi, it can happen suddenly at any time of the stage. At early, he doesn't have this microthrombi. Later on, he can have at any time of his course of the disease. Okay, Dr. Nama. Dr. Samir being a gynecologist, mashallah. D-dimer is physiologically high. Of course, many non-specific D-dimer. Currently now I have one case, cesarean section in my ICU. Her D-dimer is 4.5. She's probably COVID, suspected COVID. We are not relying in D-dimer if you have another factors, of course. But if the patient is moving COVID, what we are doing is actually increasing anticoagulation for such case. Even today, this morning, I discussed with the gynecology consultant for this patient. We increase the anticoagulation for her from the normal they are going 40 BID, we increase it to 40 OD, we give it 40 BID because D-dimer is 3, even because suspected COVID. We don't control now until now COVID, but even she's pregnant, and yes, I agree with you, but we have to consider. Dr. Dalia, she's plasma. والله يا Dr. Dalia, I hope we have another results here. We don't have many cases, but I'm sure in Saudi Arabia within a few months, it will be published more than 100 cases with convalescent plasma from all centers we can find. Can we start molecular weight early? Yes, but moderate to severe cases. The patients outside doesn't need. The patient inside the hospital and ICU, we are starting early based on the D-dimer. And we have a protocol. By the way, everything we have a protocol. Again, I will not go with the details, but we have a protocol for everything. I take longer time. Oh my God, so much. But introduction plus my lecture here. Thank you so much. Any more questions? Okay. Thank you, Dr. Shahzad. MashaAllah, he's ready now. Yeah, boss, welcome. Dr. Shahzad, one from the very our active consultant everywhere. He's, MashaAllah, now in King Salman Hospital, just for the crisis management. We are covering all the cluster group, cluster hospitals. He's responsible for the King Salman since a long time. And he has his own experience with COVID-19 patients. Before you will start your lecture, ya boss, did you try colchicine? Baya. Or the new name was called Lala? Lala. This Pakistani word he's teaching us. Your mic is not working.
Now I think my voice is clear, Dr. Mahdi.
Your voice is clear, boss, but your screen is not yet. Your iPhone mobile with double SIM card is not clear. Yes, now it's clear.
Okay, that's great.
I'm asking before
Dr. Mahdi,
you
thank you very much for inviting in the lecture, and really, maybe I listened the lecture less, but I was enjoying your voice more. I think it's long. There,
you make me flush.
We did not see each other. Same hospital, same facility, same critical care, but I think we didn't meet each other since 5-6 months. I think.
Oh, about yes.
So it's a very long been. So really, I was missing that. I mean, we are not meeting any of our colleagues. Regarding sir colchicine.
Yes.
Actually, in Salman Hospital, what has that I have an area which is called B2, where we can ventilate 5 patients on ventilator and the 15 patients on oxygen. Means mild to moderate disease, where we tried colchicine. Actually, going back, we have, I think, Greco-19 trial, where they had, I think, 100 patients, and they was having 2 control and the evidence-based arm. They find some benefit in those patients having a myocardial injury. When you start colchicine, those who were having more myocardial injury, they were having less clinical deterioration as compared to those patients who didn't receive. I was in discussion with the head of medical department there, and he was using in his patients in medical wards. So I just started with 5 to 6 patients. Dose 1.5 milligram stat and 0.5 milligram BID for 7 days. I have still the data. 5 patients out of 7 improved and discharged from ICU. So I think we should keep, as you are the national command and control for the protocol. So just I was having a comment that keep an eye over the colchicine as well.
Waiting for your result, you're supposed to add it in our protocol. Really?
Khalas, okay. I mean, I will be giving. and we can publish with the 5 patients.
Sure,
No
of
doubt.
course. Wallah, great job, wallah, mashallah. You have now your own institution, mashallah, your own experience. Great job, wallah, boss.
You're right. Alhamdulillah.
Or Lala. I like Lala now. Bye.
So Lala is a word which is called Pashto language in Pakistan as a brother. So like Madi Lala.
I will let you enjoy with Dr. Shahzad, and excuse me, Ahmad and the attendees, I will go for my round. Excuse me, Dr. Shahzad, okay? Thank you so much.
Sure, sure, sir. Thank you very much, and welcome to the all participants. Actually, we are doing, this is the 10th course for the critical care. Even the non-critical care people enjoyed, and they got a lot of knowledge-based information from this course. So I hope you all will be getting benefit, inshallah, from this course. So my name is Shahzad Ahmed. I am recently as a director of ICU at King Salman Hospital, but my base is as a consultant intensivist in King Saud Medical City, Riyadh. So today my topic is going to be COVID-19 case definition and pathways. Till 3 to 4 months, I am sure that everybody who is in the medical field, he knows the case definition, he knows the pathways, especially working in the tertiary care centers. But what happens, the course and lectures are always being organized to which you have the scattered thought process. You usually get all these things in an organized way in a course that is meant to deliver in the courses. So I will go with the case definition. I will be informing all of you about the pathways. But what happens, you will be organized at the end of the lecture that this is the real case definition. You can talk between the colleagues, between the junior staff, even being the nurses. You can teach them in an organized way. This is the purpose of this course. Contents of my course will be having an introduction of COVID-19. By the way, I think all of you know about the COVID-19. I will go through quick, but we will have a background knowledge that how this COVID-19 evolved. Epidemiology, discussing the mode of transmission, having a quick signs and symptoms. We'll go to case definition and the pathways. As Dr. Madi said, that our Saudi guidelines, which is called CDC Wakaya, these are the guidelines almost similar to the international standards. I hope at the end of the session, you all will be able to have an introduction, the causes of coronavirus, and you can enlist exact sign and symptom with evidence base, case definition, and you will be able and to know the pathways of admission, how the patient is coming in emergency room and then going to the ward, critical care department, as well as we will have a one slide that if healthcare worker is affected, what the guidelines says, especially the Saudi guidelines. So we'll start with the introduction that coronavirus. Actually, coronavirus is not only COVID-19. These are before also coronaviruses came in the world in 2003, 2007, 2012. Coronavirus was there. They have a family. It's called Coronaviridae, and the subfamily is Orthocoronavirinae. Actually, subfamily has two. It's Orthocoronavirinae and Toronavirinae as well. But mainly common is family is Coronavirinae, which has 4 genus forms: alpha, beta, gamma, and delta. Beta has 2 parts, beta 1 and beta 2. The COVID-19 belongs to the family Coronaviridae 2, beta group 2b. You know the viruses are enveloped and viruses are non-enveloped as well. So COVID-19, especially, these are the enveloped viruses, and they have a positive sense single-stranded RNA genome. So they are sensing single-stranded RNA genome. Why we call it coronavirus? Actually, if you see the picture in this slide on the right side, when we view under the electron microscope, they show club-shaped protein spikes. And corona means crown, hollow. So it looks like a crown and then having a surface covering in club-shaped protein spikes. If we go with the epidemiology, as I told, I was here in Saudi Arabia in 2003 when the SARS-CoV-1 came. It spread to the Saudi Arabia. It was in Makkah as well. So it affected a lot of people. At that time, a lot of campaign was run in Saudi Arabia to having a prevention control, but not as COVID-19. Then Middle East respiratory syndrome, most of the physicians know about it, MERS coronavirus, same MERS coronavirus in Saudi Arabia with camel epidemiology, it came in South Korea as well. But it was being controlled because it was had an epidemiological link, and it was controlled at that time. And now we have 2019 and 20, COVID-19, but this is not the outbreak. It is a pandemic. It involves whole the world. More than 200 countries have been involved with COVID-19. He started in Wuhan city of China in December 2019. That's why it's named at COVID-19. CO for corona, VI for virus, D for disease. So coronavirus disease 2019. And term name was 2019, but later on the World Health Organization studied this virus. It is almost a resemblance with the SARS-CoV, which came in 2003. So it was the taxonomy of the virus name was given as SARS-CoV-2. Is it lethal? It is pandemic. If we see this slide, this is the slide of today, statistics. So if we see the worldwide cases, up till now, 13 million cases have been positive all around the world. And it's so deadly virus that 500,000 people have been died up till now. Though the recovery is still there, 7.6 million people got recovered, but deaths are 500,000, which usually goes to the 7% of the deaths of the total population which have been affected with the COVID-19. Though 93% have a recovery, but 7% deaths have been noted all over the total persons affected. If we come to the right side of the slide, we can see in Saudi Arabia. So Saudi Arabia was having cases. It was having 235,000 cases have been reported till today. We are lucky that we have very small percentage of mortality, which is 1%, as compared to the world where the mortality is 7% and recovery is 99%. So the death toll is 2,200 people and the recovered people 169. Other people are still admitted into the hospitals and 3% people are in the critical conditions. So these are the data up till today. Mostly people who get infected with COVID-19, they get acute, severe or mild respiratory illness. It has a unique pathogenesis that affects upper respiratory tract infection and the lower respiratory tract infection. Dr. Madi, in the previous lecture, he has mentioned very clearly about the incubation, prodromal phases, symptoms and signs, going with the pneumonia and having immunological markers. But here, the data shows that patients are presenting with upper respiratory tract and the lower respiratory tract infections. This is the slide which I already told that it is caused by SARS-CoV-2, which is almost resembling with the SARS-CoV-1 in 2003. Started from Wuhan city of China and identified as group 2B beta coronavirus. It is initially was thought to have a zoonotic origin, but later on, it has been proved that patient, if having a respiratory droplet, can be spread through the respiratory droplets and contact route as well. So its mode of transmission is through respiratory droplets. It can be through the airborne. So if respiratory droplets are coming on the dead sites of the infection, metal, thermometer, stethoscopes, the things which are in our use, so it should be disinfected with the ethanol, which is 62 to 71%. Does it have a fecal-oral route? Very minimum studies, 1 or 2 studies are up till now in 6 months evolved, that patient coming with the intestinal manifestations are having a COVID-19 positive. If we go with the respiratory droplet, so respiratory droplet, actually we need to understand that respiratory droplet is of different sizes, which can be measured according to the diameter in size. So droplet particles, if it is more than 5 to 10 micrometer in diameter, they are known as respiratory droplets. If it is less than 5 micrometer in diameter, they're called droplet nuclei. The current evidence of COVID-19 says it's primarily transmitted between the people through respiratory droplet and contact routes. Now, if you have the respiratory droplets, which is in more than 5 to 10 micrometer in diameter, and if the person is in close contact within 1 meter, or patient started to cough or sneeze, then it can have a risk of having mucosa contaminated with or exposed to this COVID-19. But those droplet nuclei who are in light in weight, light in size, if they can go more than 1 meter distance. That's why the persons who are healthcare workers have been advised, once they are in contact with the patients, they must take all the precautions of airborne transmission. Now, incubation period ranges from 1 to 14 days, but we have seen mostly the patient comes with the incubation period of 4th or 5th day. Incubation period is this: once you are infected with COVID-19 and you exhibit with the manifestation or signs of disease, it usually comes at day 5. But some cases, initially in April and May, we saw many patients who were in contact with the close contact, or they were referred as suspected cases. Their incubation period extended to 27 days as well. What are the signs and symptoms? It can be specific, it can be non-specific. Infected persons may be symptomatic, may be not symptomatic. They can have a initially flu-like symptoms, like fever, cough, fatigue, shortness of breath, or muscle pain. But atypical symptoms can occur in specific patients with the gastrointestinal manifestations. Look at the percentage of patients where we are finding that the patients coming with the fever having 87.9% as a sign and symptoms of this disease. If we go down with the dry cough, 67% people comes with the dry cough. Same way, having a shortness of breath, and very recently was labeled that patients are coming more with intractable headache as well. So these are the symptoms and signs, even though have been seen few cases with conjunctivitis. 0.8% people mostly reported in America and especially in the New York. But there were few cases who came with the conjunctival congestion and patient was positive as COVID positive. Though it's not common, but the intestinal manifestations like nausea and vomiting, 5% of the people still exhibit the intestinal manifestations. We will come to the interim definition. This guideline taken from Vikaya, which is CDC guideline of Saudi Arabia. They given us this definition in the month of April. 2nd April was released and we were following these guidelines. But in the next slide, remember, it is another updated guideline which came in 13th May. So I will go with the definition of case definition of COVID-19. Those patients who are coming with clinical presentation and having an epidemiological link can be suspected as COVID-19 cases. So clinical presentation chart, if we see the patients coming with respiratory illness, like sudden onset of at least one of the following feature: fever, cough, or shortness of breath. This fever can be measured or can be by the history. So fever, cough, and shortness of breath, any one of these having an epidemiological link can be suspected as a COVID-19 case. And in the 14 days prior to symptom onset, met at least one of the following epidemiological criteria. What is the epidemiological criteria? That patient have visited the high risk endemic areas where the COVID-19 patients were more, and he visited that area. Like Riyadh city, Jeddah, Makkah, Medina, Qatif. These are very high risk areas. Now many areas in the specific city are designated that this is having a red sparking zone where more cases of COVID-19 are there. Or you have a physical contact with a confirmed COVID-19 case, or you are working in a healthcare facility and you're working in the COVID area. So this is the epidemiological link. And if you have any one of the symptoms like fever, cough, shortness of breath, is a definition is to define that you are a suspected case of COVID-19. You should go for further management like testing and diagnostic workup. Those patients who are admitted in the hospital with unexplained community-acquired pneumonia or hospital-acquired pneumonia, they doesn't need epidemiological link, but they need to fulfill the criteria as a suspected COVID-19. Look at this criteria, which came in 13th May, 2 months before. It was an interim guideline to have a suspected case definition. In this, they said now the person who is coming with respiratory illness, like fever, cough, or shortness of breath, he doesn't need to have epidemiological link. He must be suspected and must be swabbed. If he's stable, he can do the home isolation. Unstable, he can do the hospital isolation according to the stability criteria. We will come on the next slides. Then the same, they keep it number 3, that unexplained community-acquired pneumonia or hospital-acquired pneumonia, no need for epidemiological link, and he can go with the suspected cases of COVID-19. The number 2 was new, that the patients are coming with headache, sore throat, rhinorrhea, nausea, and diarrhea. And in the last 14 days prior to symptom onset, if he has the epidemiological link, needs to be swabbed. Like he had a contact with a confirmed COVID-19 case, or he lived in or worked in a facility known to be experiencing an outbreak of COVID-19, or if he has traveled with any COVID-19 in any kind of transportation, must be suspected for COVID-19. So I hope here you guys understand that one case definition came on 2 April, 2nd April, where there the epidemiological link was mandatory. But the next guideline came where they say the fever, cough, shortness of breath is coming, we need to swab. And even now, I think the new guidelines supposed to come where there are some high risk cases, immunocompromised patients who are presenting to the emergency department of the hospitals, they will be screened regularly that they need isolation, suspected, and get the result positive or negative. So here, remember that number 1, no required, but fever, cough, shortness of breath fulfill the suspected COVID-19 case definition. Epidemiological link with the symptom of headache, sore throat, rhinorrhea, nausea, and diarrhea in the last 14 days prior to symptom onset, and unexplained community-acquired pneumonia or hospital-acquired pneumonia. What is a confirmed case definition? The person whose laboratory testing PCR is positive for COVID-19, it is a confirmed case of COVID-19. This is the definition. Close contact, as I said before, healthcare associated exposure, working together in close proximity or sharing the same classroom or hostel environment with the COVID-19 patient, traveling together with COVID-19, or living in the same household defines as it is a close contact. Clinicians must be aware with the atypical presentations, specifically in the immunocompromised patients. In immunocompromised patients, he should see those patients like renal transplant, renal failure, congestive heart failure. They should go with the more low threshold for the COVID-19 suspected definition. I hope this slide is known to every one of my colleagues. That is present since 6 months in the respiratory triage checklists, which is showing the same definition which we have discussed. That one of the respiratory criteria and following the epidemiological link. If it has more than 4 score, then ask the patient to perform hand hygiene, apply the face mask, and send him to the respiratory pathway in the emergency department to see that whether it's going with the suspected case, meeting the case definition, needing the necessity of swab. So how we are making score 4? Very simple. 3 score is for epidemiological link. So 3 score for epidemiological link, as we discussed previously, that the person who is in physical contact with the confirmed case of COVID-19 or living with him, or the healthcare facility worker who is in touch with the COVID-19 patient, scores 3. So now you need 1 more score to have a suspected definition. So if the patient is coming with the fever, it scores 2 in adults, or cough, 2 scores, or shortness of breath having a 2 scores, while intestinal manifestation have a score of 1 in adult people. So if any one symptom plus epidemiological link, he fulfills the criteria to have a suspected case definition. Pathway, patient came in ER, you did the visual triage, meet the case definition, and if it meeting the case definition, we will take him to the immediate life-saving areas where it is noted to be as a stable or unstable case. If he is stable and it doesn't need any life-saving procedure like use of high-flow nasal cannula, rebreathing mask, CPAP, or intubation, then it will be assessed stability. If not fit for stable for home, he will be taken to the ward or he will be taken to the critical care area. If he is stable, fit for home isolation, swab the patient, notify the MOH. What is the criteria of stability? If his respiratory rate is less than 20, if he is maintaining saturation more than 92% on room air, and radiologically his x-rays are fine, there is no more infiltrates are there or ground glass opacity, considered as a stable case. If not fit for home, bed management will be informed and he will be admitted directly. And if he is not meeting the case definition, he will follow the regular triage system. Now, after this visual triage and having an assessment at ER for isolation, and we will see the critical care physician for stabilization, scoring, and will do the assessment. If patient needs any airway procedures, they will do this one. And if they are in need to move the patient, then there will be a specific bed is ready in the ICU, and minimum time is 15 minutes to take this patient from ER to the ICU. Medical on-call must accompany the patient to ICU and begin the admission process there if not done in ER. And the critical care physician will be stabilizing the patient if there is any life-saving procedures are there. Once it's done.
It's 5 minutes left, please.
Sure. So when it's done, 2 nasopharyngeal swabs for COVID-19, and if the consultant thinks that it has an epidemiological link for MERS-CoV and H1N1, he can do for this, and we will inform 937, fill out the form, get the Hassan number, and transfer these samples by the SAMHSA. If positive COVID, we will treat as COVID-19 criteria. If negative COVID, then we will wait for the other results. If negative, we will go to stability of the patient. This is the pathway of transferring COVID-19 positive patients from one facility to the other. Initially, like cluster 1, C1 cluster, as we know, King Saud Medical City, it has 3 hospitals under it. So how to move 2 hospitals were recognized as a red zone, different phases. And we were saying that the patients who will come to the non-COVID hospitals, how to move this patient to the COVID centers. Like we were shifting the patients to Imam Abdul Rahman Faisal Hospital. So if there was any COVID positive patients, there was a specific hotline. Crisis management team was there who was arranging the medical report, a HALA number, then preparing the ambulance, specific ambulance for COVID-19 patients, preparing the team, providing them all the PPEs, and they were transferring the patient to the designated hospital. We'll come to the isolation precautional pathways, that what we do, that how much duration of isolation precaution pathway. Remember, every hospital can have their own infection control guidelines, but Vikaya, Saudi CDC says in the confirmed cases of COVID-19, define yourself that patient is symptomatic or asymptomatic. If symptomatic, then wait till the patient clinically recovered. Once clinically recovered, do the retesting. If positive, repeat every 72 hours. If negative, do another sample. Once you get 2 consecutive negative samples 24 hours apart, he can be discharged from the hospital. He can be moved out of the home isolation as well. In asymptomatic patients, we will do the testing. Once it comes negative, 2 negative samples are needed, and patient can be out of the home isolation. Suspected cases, same. Tested initially with COVID-19 positive. If comes positive, we'll go with the same confirmed and asymptomatic pathway. If clinically unstable, it must be admitted to the hospital for isolation for 14 days. If suspected case is clinically stable, then home isolation or high isolation designated facility may be considered by the National Command and Control Center. This is my last slide, which was updated on 2nd May 2020. Return of healthcare worker infected with COVID-19. So the previous slide, as we were saying in the start of the pandemic, that the 2 samples are needed for the patient person to be out of the isolation. So here we were having the return of healthcare worker who has been infected with COVID-19. If he is asymptomatic, get retested for COVID-19 at 3rd day of confirmation, and then get 2 consecutive negative nasopharyngeal swab. If negative 2 consecutive samples, he can be reported back to work. If he has symptoms, wait till he has get the resolution of symptoms. When resolution of symptoms done, then he will be repeating his sample every 72 hours. Once it gets negative, then get another negative and let it to come back to the work. I know that some cases, especially if ICU colleagues, even 1 sample became negative, they came back for the work. If you're exceeding time, healthcare worker is above 5 days have been done, then 1 negative sample taken after 5 days or more is enough to return to the work. Now you are COVID positive, your sample was first positive and then became negative, but you have to take the precautions after joining to work. Source control must be done by wearing the face mask, and you must self-monitor yourself for any signs, symptoms, and if there are signs and symptoms, then report to the team. Thank you very much for listening me. I hope you got some background organized knowledge about this. Any questions? So I can ask. We can. So Syed Ubaidullah is asking me presently for the staff. If this is a question about the return of healthcare worker, it applies to these guidelines which have been released in 2nd May, my last slide. And if he is negative COVID, probably no need for 2nd sample, and you can report back to the work. But again, it goes to the local infection control guidelines. And for example, one of our colleague, he was, I think, 10 or 11 times remained positive. Every 3rd day sample was sent and it remained positive. So it took around to get negative 30 days while he was having clinically symptoms as well. So 1 negative sample is needed to be to say that it's COVID negative. How we depend upon a lab to allow healthcare worker to back to work while sensitivity is 70%. At this present time, we have this testing available, and this is the best sensitivity that we are using. We don't have any test to say that it's 100% sensitive or more sensitive. So which test have a maximum sensitivity, you have to go with this. There can be false negative, but it can be decreased false negativity only by having the swab testing by good reagents from a known from the known companies. The reagents are coming, but what is the available sources, we have to depend it upon it. I mean, we sacrifice the healthcare worker. I mean, it's not the sacrifice. We are the front liners, and we are proud of it. And we have to take the precautions and full precautions with PPEs. And it's not the sacrifice at all. We are since 6 months are here, and the country needs us. Country is providing us the full PPEs, so it's not the sacrifice. But if the sampling you are telling, yeah, it can be with the local infection control and according to the guidelines of the local sources. If it is differs, this is another thing that every institute should think about his employees. But sacrifice, I don't agree. This is the frontliner. And I will say this is a proud feeling time for us that we are serving the humanity, and this country needs from us a lot of efforts. and we should do these efforts. Following symptoms-based strategy for healthcare worker return to work. So symptoms I discussed as earlier, that if he has a continuous dry cough, he has the continuous body aches, muscle pains, any intestinal manifestations are there, then these are the symptoms. If it is not getting resoluted, we should take the rest at home. We should our institute must know about it, because you are talking about the sacrifice, but at the same time, what is needed from us, that we should be so careful that we should not be a source to disseminate the infection. So I agree on this level, that symptoms must be resolved to return to the work. This is a genuine reason, and not to infect the other patients or colleagues. All the symptoms, if it is resoluted, then coming back to the work is logic. Good lecture, thanks. Thank you very much. Local infection control protocols are to be followed. Yes, Dr. Mona. Samir is saying sacrifice if we depend upon one swab result. Multiple institutes are doing one swab result. If it is negative, then they are asking the employees to come back. I think Dr. Tasmia will be with us as well. And the next lecture, if she is the one, I will ask her to highlight this one about King Saud Medical City, how we are going with the healthcare worker, this one. What is the approximate percentage for false positive of the current available test? They say, I think it's 27 or 25% is the false positive results are there. 25 to 27%.
Thank you, Dr. Shahzad, for your excellent presentation and lecture.
Thank you, Ahmed.
Thank you so much. So now we will move for Dr. Tasmia. Dr. Tasmia, she is the ICU specialist, and she's responsible for the infection control also. So can you share your presentation, Dr. Tasmia? Dr. Tasmia, can you make any mute for yourself and share your presentation also?
Assalamu alaikum everyone. I'm just sharing my presentation. So, Assalamu alaikum everyone. I'm Dr. Tasmia. I'm an assistant ICU consultant and CCD coordinator for infection control. Today, I will just be talking about the personal protective equipment and also the infection control measures that you need to follow for a suspected or a confirmed case of COVID. As healthcare workers and being in the front line, it is very important for us to know what kind of PPE we need to wear and how we could protect ourselves. So safety plays first, and hence we need to...
Dr. Tasmia? Dr.
Yes.
Tasmia?
Yes.
Your screen is not sharing.
Is it okay now?
No, not yet.
Not yet?
I will share your presentation from my side.
Is this okay now? Still not okay? Dr. Kunal, still okay?
I shared your presentation. I'll just start.
Okay. Okay, so as we all know that there was a big controversy regarding what kind of an infection it is. So initially they said it is a droplet infection. However, now they claim that it is an airborne. Precautions need to be taken, and hence it is very important for you that you follow contact precautions, standard precautions, as well as airborne precautions, especially with your eye protection. So they claim that this kind of a virus can be present in the air for at least a period of 8 hours. So hence, it's better to maximize all your precautions, take all precautions that you would normally take for an airborne isolation. Now, to go on to the basics, hand washing is the single most important and easiest method to reduce the transmission of pathogens. However, since we don't have sinks and available at all places and not very convenient in location, we do encourage all of you to use alcohol hand rubs, which are easily available and where as much as possible, and to make use of them. Next slide, please. Hello? Hello?
Yes, Dr. Tasmia.
Yes, I cannot see the slides, Dr. Kohel. Are you sharing them or?
Now it's the steps of hand hygiene.
No, I cannot see the display on the thing, on the screen.
It's displayed now. You can just
Okay, so the next would be the steps of doing the hand hygiene. So what's important is, of course, you need to make sure that all your prerequisites are met. You need to cut your nails. You need to make sure you're not wearing any gadgets like wristwatches, any rings, any kind of jewelry, and so on. So it's very important for you to make sure that these prerequisites are met. And then after this, you need to go about doing your hand hygiene. Now, also when you're using your alcohol hand rub, it's very important to at least spend a minimum of 20 to 30 seconds while you're doing your hand rub. So these are the following steps which you need to concentrate on. The first, of course, is palm to palm, then followed by palm to dorsum. So you need to do it on the vice versa. And then followed by the fingers interlaced, which is the next step. So as you are doing this, you need to actually apply a lot of friction. Then comes the back of the fingers to your palm with rubbing it across, and then the thumb, grasping the web space of the thumb, as well as rubbing the thumb with friction, and then the tips of the fingers onto your palm with a forward and backward motion, and then finally the wrist. So with this, all your steps for the hand hygiene or the hand rub is complete. Now, when you are doing the next slide, please. So whenever you are doing the hand hygiene, like washing your hands, it is very important for you to spend double the time that you need to spend on hand rub. For example, you need to spend at least a minimum of 30 seconds to 1 minute while you do your hand wash. Next slide, please. So as healthcare providers, it is also very important for us to get a N95 fit test done. It is mandatory for anyone working in the COVID areas. Just try to contact us and we will try to facilitate the N95 fit test if you haven't been done with it. So this is a fit test which would help you know what kind of a mask would actually fit you or would provide you with the best fit. Now, if you fail your N95 mask fit test, you need to go on or you need to wear what is called the popper. On your right side, what you see is a powered air purified respirator. And this is what is required for those, especially with the beard and those who have not been fit tested for N95 mask. So we also have these hoods available, especially for those where it is, those physicians where it is really indicated. Next slide, please. There are certain basic things that you need to follow, especially these are like cough etiquette. This is mainly prevents the transmission of respiratory infections. Now, what you have to do is you need to cover your mouth and nose with a tissue, especially when you're coughing and sneezing, and dispose of the tissue in the nearest waste receptacle. So after you're done with this, you need to do your hand hygiene, and especially when you come in contact with respiratory secretions. So this is the basic cough etiquette that needs to be followed. Next slide, please. Now, this circular was forwarded a few months back, and in our Outlook, and this mainly specifies the personal protective equipment that you need to wear, especially when you are handling or taking care of any activities, especially related to a suspected or a COVID patient. So remember that what we practice now is universal masking. Universal masking is recommended, especially at every hospital premise, as well as when you are in the patient areas. So at the point of entry, make sure that you are wearing a surgical mask, okay? And also as well as while you are in your restrooms or in doctor's rooms, all these things you need to make sure that whether it's in clinical or non-clinical areas or administrative areas, make sure that you are wearing your mask. The second thing is, of course, when you are transporting a patient, which is a suspected or confirmed, these are the following PPEs that you need to wear. You need to put on your surgical mask, the goggles, gloves, as well as a gown. The practice of wearing a N95 mask, what you actually see is being followed, especially for aerosol generating procedures. Now, for an aerosol generating procedure, you make sure that you have your properly fitted N95 mask, which is available. Wear your goggles, wear your gloves, and you also need to put on your surgical gowns. Now, in many cases, surgical gowns, if not available, Ebola suits can be used for aerosol generating procedures. So all these PPE are a must, especially when you're doing your aerosol generating procedures. Now, subsequently, I will just tell you what the aerosol generating procedures are. Let me tell you what we follow here is the extended or the reuse of N95 mask. In the extended use, we make sure that we are wearing an N95 mask, and above it, we put on a surgical mask. Okay, so whenever you are, so that this mainly reduces the contamination of the mask itself. Now, by reuse, what do you mean by reuse is sometimes you wear your N95 mask, and then after the use, you would try to store it in a paper bag. Now, generally, what we practice here is extended use, but you could also go for the reuse. The maximum number of reuses that is allowed is about 5 times, and then follow that, you need to discard the mask and use another one. Or you could use the mask that is for aerosol generating procedure. If you have done an aerosol generating procedure, you need to discard the mask and then use another N95 mask. Next slide, please. Now, it is also very important for you to know what is the sequence of wearing your personal protective equipment. So the first step, make sure that you put on first is to do your hand hygiene. It is also important to have an assistant with you who would correct you or would actually help you put on your PPEs, especially when it comes to wearing of your Ebola suits or your PAPR devices. It is very important that you have an assistant. Now, once you are done with your hand hygiene, it is important that you put on, first check if you have all your personal protective equipment of appropriate sizes, especially the gowns, the masks, the N95 mask, the Ebola suit is of the particular size, and so on. So the most important is, of course, you will put on your gown, make sure that you cover your entire attire, and then you anchor the ties, especially at the nape of the neck as well as your waist. Now, before this, or before putting on your PPE, make sure you do not carry unnecessary gadgets with you. Make sure if you have scrub suits or disposable scrub suits, you put on your disposable scrub suits. And if you are using your own, you could use your own scrub suit. But later on, make sure that you need to change on to a new set of scrub suit or another attire before you leave your area of work. So this about the gown. Of course, after you wear the gown, the second is the N95 respirator. If you're wearing your N95 respirator, make sure that you do a seal check. You mold onto your nose piece of the respirator, then take a deep breath and exhale. Now, when you exhale, there should be no escape of air around the mask. So this means that your fit is proper, and you can use this mask. Especially use the N95 mask only that has been fitted best for you. Now, subsequently, we will be having another automatic machine which will do a fit test for you. As of now, we have certain area. We have nurses who perform or are assigned with this task, but subsequently we would come out with another type of test that would be automated, and that would give you your best fit for your face contour. The third is, of course, you will have to, can you go back please? This is for the removal of the PPEs. Dr. Kuhel, I need the previous slides. The previous ones, sorry. No, before this. How to put on the PPEs. I just need to go back. You need to go back on the slides. Back, yes, back. A little more back before this, yes. The third thing, of course, so we finished with the wearing of gown, then the mask, and the third one you would wear, next slide please, is you would put on your goggles. So when you're wearing your goggles, also make sure that you do not touch the front surface of it. You try to hold it on with the bands, you try to place it, and then you go back to next slide, Dr. Kuhel. Yes, so you put on your goggles. Once you wear your goggles, remember if you are wearing your spectacles, this cannot act as a replacement. You have to wear your goggles over it. And then the last you would wear is your gloves. So when you're wearing your gloves, make sure it extends up to the extended cuff of your gown. So with this, you're done with wearing your PPEs, and then you are safe to go inside. So make sure that all of these PPEs are worn, especially when you are handling such suspected or confirmed cases. Next slide, please. Yes. The sequence for removing the personal protective equipment is also important, especially when you have to, this actually reduces the contamination. So you all know that the gloves are the most contaminated, so you need to remove your gloves. So this is done by the pinch and glove technique. So you pinch one aspect of the glove, you remove it, and then you slide the ungloved finger within the glove, and then you remove both the gloves in toto. So once you are done, remember for every step of removing your PPE, you need to do your hand hygiene. This is very, very important because at these steps, there are high chances of you contaminating your hands. So please perform your hand hygiene at every step of removal. Then you need to remove your goggles or your face shield. So it is important, again, never to touch the front surface of your face shield. Remember, you are provided only with one face shield in your shift. You can go about doing the cleaning of the face shield by wearing a pair of gloves and cleaning the front surface by means of alcohol wipes or the wipes or the disinfectant wipes that are available in the unit. Now, once you remove the goggles, next slide, please. You are left with your N95 mask and your gown.
There's some sounds around you, like air or like AC is around you. If you can be away from that.
Okay. Okay, fine. So after this, of course, you have the gown. You need to remove your gown. Remember, all of these are inside the isolation room. So you will remove your gown, and then you will lastly remove your N95 respirator. However, if you're going for extended use, you need not remove your respirator. You can just come out, and you could be wearing your surgical mask over it just to avoid any contamination. Next slide, please. So it is very important for us to report all our suspected cases to the Ministry of Health, and this is mainly done by means of calling 937, and we also notify this by means of Health Electronic Surveillance Network. Remember that we take nasopharyngeal swabs, especially for those who are spontaneously breathing, and in case of intubated patients, what is recommended is a lower respiratory tract secretion. And especially this procedure, or since it is aerosol generating, needs to be done in a negative pressure room, or it could be done in a single room with a HEPA filter. Next slide, please. Now, we finished with the hand hygiene, the use of personal protective equipment. Now, what's important for you is, of course, to know that there is a certain pathway for the admission of these patients. All patients with respiratory symptoms, they are scored with a checklist. They are scored, if score more than 6 or score more than 4, they get admitted into the triage and then into the isolation units. Now, again, what kind of precautions you need to follow is standard contact and airborne precautions, including your eye protection. Next slide, please. And the other things, especially respiratory etiquette, social distancing, all this needs to be followed. So it is also very important that if you have a patient with respiratory symptoms, it is important to contain the cough. So this can be done by source control, can be achieved especially by making the patient wear on a surgical mask. So this is very, very important, especially if you have a patient who is spontaneously breathing. Now, where do you place these patients? We place these patients in negative pressure rooms. However, since not all facilities have the facility for negative pressure room, we can keep them in single rooms with a HEPA filter. Now, the HEPA filter is generally kept at the head end of the patient. Try to limit the number of personnel entering into the room, especially if you have any kind of aerosol generating procedure. A minimum of only 2 or 2 to 3 should be inside the patient's room. And a logbook, if you see, is maintained about who is entering into the patient's rooms, because this would help us in contact tracing or in cases where there could be exposure to a confirmed case. Next slide, please. Now, as you see in our ICU, we also have cohorting rooms. So once they are positive, we move them to a cohorting area where a number of cohorted positive patients could be. Now, what are aerosol generating procedures? Tracheal intubation, non-invasive ventilation, tracheostomy, cardiopulmonary resuscitation, manual ventilation, before any intubation and bronchoscopies, all these are airborne or aerosol generating procedures. So anyone doing these procedures, make sure that you are N95 fit tested. If you are not N95 fit tested, never do such procedures. Someone needs to be done in negative pressure rooms. Next slide, please. Next slide. Next slide.
Dr. Tasmia?
Yes. Next slide. Okay. So as you also see that all COVID, the previous one, we also dedicate equipments for our COVID patients. As you see in our previous slide, we have machines, especially the X-ray machines, the dialysis machines, all equipments for the COVID patients are dedicated. We do not have to share these between our normal clean patients. So once used for our COVID patients, we generally keep them, we clean them, we disinfect them, and keep it ready for use. Also, the elevators that are used are separate, or they are separated, especially for infectious. Next slide. This is the transport capsule, what you see, and this is used especially for transporting the COVID positive cases to other hospitals or especially to other facilities. So this is the transport capsule. It is a negative pressure capsule, and we use this for transporting such patients. Next slide, please. Transportation of suspected cases. Now, if you need to transport such cases, it is also very, very important that you wear all your necessary precautions. You take all your necessary precautions. Like, for example, you need to notify the area that they are going to receive such positive patients. It is also important for you to be wearing PPEs, all your PPEs. Put on a surgical mask, especially if you have a patient who is spontaneously breathing. Use the routes of transport which are, not very crowded or where there's no traffic. And healthcare workers transporting should wear all complete PPE. So make sure you put on an N95 mask, especially if you are transporting the patient in an ambulance. And if any aerosol generating procedure is expected to happen, or if you anticipate any tube dislodgement or anything, you need to wear on your N95 mask. Now, transfer of these patients is done by means of a special elevator or dedicated elevator, as I already told you. Now, once you reach the area or once you have already transferred, remember to remove your PPEs, especially after you transfer the patient, and then return back to your area. Now, when you are transporting patients also, we make sure that the wheelchairs, the stretchers, and all kinds of equipments that have been used are disinfected, especially after following a contact time. If transfer to another hospital is really needed, we use a negative pressure ambulance. Staff accompanying the patient during the transfer should remove all the PPE after the endorsement and to the receiving hospital, and then wear another new set of PPE before coming back to the ambulance. So it is also important that you remove all the PPE at the EMS entrance door, and terminal cleaning of the ambulance should be carried about, and ambulance disinfection should be done using a fogging machine. Next slide, please. Now, how dedicated medical equipments need to be used. Again, when you're using stethoscopes or when you are using, please make sure that you disinfect in between patient use. Also, all equipments are dedicated for the use of COVID patients, as already described. So also we make sure that cleaning and disinfection is done consistently. So we follow a certain protocol of terminal cleaning and disinfection, whereby we concentrate on the frequently touched surfaces, the bedside rails, the bedside and over bed tables, and so on. So all the surfaces, including the horizontal surfaces, are all cleaned. Next slide, please. Now, apart from all the precautions that I already mentioned, there need to be certain general precautions that you need to take. Ever since there was an outbreak in the Wuhan area in China, or the Hubei province, it was found that you also need to it was mainly linked to the animal markets. So it is very, very important that you wash your hands, especially if you have come in contact with any animals or animal products. Never touch your eyes, nose, and mouth with bare hands. Never touch any rotten animal products or any other in the markets. Not touching animal waste or fluids in the markets. Avoiding consumption of undercooked animal products, and patient with comorbidities, especially high risk of severe infections, should keep away from stray animals. Next slide, please. Now, all exposed healthcare workers should report. Of course, we do have healthcare workers being exposed. So it is very, very important that if you are symptomatic, you need to report to your immediate supervisor about your symptoms. So never come to work with your symptoms. The second thing is, of course, if you have been exposed to a patient which is COVID positive and you have become symptomatic, it is important for you that you notify the infection control. You would be undergoing a risk assessment based on your symptoms, based on whether you were protected or unprotected, whether you were wearing a mask or not, and so on. It would then include swabbing you from the 3rd to the 5th day of exposure. Now, if you have been symptomatic, you are excluded from work. The new protocol now says that if you have been, even if you have been a high risk exposure, and if you have been swabbed, you need to join work, however, and you will be notified by the infection control team following your results. The decision to permit the healthcare worker, again, is the responsibility of the infection control. So make sure once you are positive, again, you need to follow a certain protocol. You need to home isolate yourself. Try to monitor yourself for signs and symptoms, especially fever, by keeping a thermometer with you. Try to wash your hands before every activity, especially after coughing, sneezing, preparing food, or using the toilet. Try to dedicate your utensils just for yourself. Try to follow respiratory etiquette also, especially when you cough and sneeze, and avoid any unnecessary exposure to any sick people. So you also need to monitor your family, keep yourself socially distanced from your family if you are sick, and try to monitor each one's health. Now, patients exposed to COVID-19 cases, sometimes we do come across patients who are exposed. In such cases, you need to monitor them for about 14 days of the incubation period. We do a screening for them, and then if they are positive, we again need to follow the protocol. However, during these 14 days, at times, you need to monitor the patients for any clinical deterioration. So if there is any clinical deterioration, it's when you need to suspect and need to repeat the test. So patients are then discharged following the period of incubation, that's after 14 days of monitoring and following a negative swab. Next slide, please. I think I'm finished with the presentation. If you have any questions, you can ask me, please. There were a lot of questions that the voice and the connection was not clear. I really apologize for this.
Okay, thank you, Dr. Tasmia.
But if you have anything which wasn't clear to you and you couldn't hear me, I am here to clarify your queries.
Your lecture, because we have to move for the next speaker because of the time. It's now already 10:30 and we have 10:25 and we have another 2 lectures. So
okay.
Thank you so much.
Thank you, everyone. Thank you, Dr. Kohel.
So now we'll move for Dr. Bashir Abdurrahman. He's our clinical pharmacist. He will discuss about the treatment of COVID with the pharmacological therapy in ICU patient. Dr. Bashir, can you...
Assalamu alaikum. Is it clear, Dr. Ahmed? My voice is clear? Okay. I will share my screen. Okay. Okay. Okay, you can see. Can you see this one? Okay. I'm Bashir Abdurrahman, ICU clinical pharmacist. I will talk today. Thank you for having me. I will talk today about COVID-19 medications. Unfortunately, till now we don't have any approved medications for COVID-19 yet, but we will talk about medications or protocols we are doing for or currently we are applying for our patients. Some of those medications we are using as antivirals, others supportive medications, and there is some other under trial medications. Regarding COVID-19, small introduction, the virus structure of the receptor binding gene is almost similar to that with SARS coronavirus. That's why we are calling it's a SARS-2. And it's binding and using same receptor of angiotensin converting enzyme 2. This is related to the major or the famous question, shall we use ACE inhibitor or not? According to the recent recommendation, we are not using, of course, ACE inhibitor as for COVID-19 treatment or prophylaxis, but if your patient was taking these ACE inhibitors or ARBs, if there is no contraindication like hemodynamic instability, you should advise and you should continue those medications for the patients, because usually with those patients taking ACE inhibitors, we can see overexpressions overexpression of those receptors, that if we discontinue the medication, that we are allowing the virus to have more chance to enter the cell. That's why we are telling we should resume or continue S inhibitors or ARBs for those patients. The RNA closest to the bat RNA. That's why also they think it may come from bats. The bad news, it's positive sense RNA virus and it's enveloped, which means it's very easy to attach, it's very easy to replicate, but it's not easy to reach or to treat. So it's very or highly spreadness activity, but unfortunately we don't have any treatment yet. And of course, everyone can tell that the major issue with this virus is the spreadness. Severe illness most likely to be occur with elderly patients, but as we all see, and we have now a good experience that at any age it can affect, and severe symptoms might even invade young patients. So it's not only related to immunocompromised or elderly patients. Of course, with those with comorbidities, we are thinking about more challenges, especially if they have polypharma, there is a lot of drug-drug interactions. If they have renal impairment, some medications are contraindicated like this. But we are talking about severity. It might be with for any age, but we are making special concern for advanced age or elderly. I think many will ask why we are not preparing or why we are not doing medication for this one, and why FDA now not approved any medication even with partial efficacy. This is like to tell you that final FDA approval might take up to 12 years. So we will not have a drug till 12 years, or we have something called fast track approval. This fast track approval will tell that you can use those drugs, but for off-label use, off-label indication. So we need 1 or 2 years to have the drug, I think, but we need a clear FDA approval for this drug. We need many trials and many phases, so we might have FDA approved medication after 12 years. Regarding management, we have 2 types: home care, which is the main issue, that to focus on prevention of transmission and to monitor the patient if there is a clinical deterioration, and to symptomatic relief or treatment, like good hydration, antibiotics, and analgesics. Okay, but for hospital care, we have those list of drugs we are using now, like glucocorticoids, nebulized medication, NSAIDs, antimalarial, antiviral, interleukin-6 pathway inhibitors, convalescent plasma, and some supplements, vitamins. Regarding corticosteroids, early we thought that there is no role to use any corticosteroids with COVID-19 because we have 2 bad experiences. First one, that corticosteroids might increase mortality with those patients with influenza, and it will delay viral clearance with MERS-CoV. So everyone was telling you should avoid to use corticosteroids. WHO and CCD recommend that corticosteroids should not be used routinely for all patients. But as a critical care practitioners, we put some exceptions before that for patients with COPD exacerbation, with asthma, with ARDS, septic shock. Of course, we have to use corticosteroids, and it seems to be correct. Those the suggested doses of corticosteroids, if there is septic shock, 50 milligram Q6, and if there is ARDS, we are using 1 milligram per kg, and we may reach to 400 milligram per day, but in some protocols. So we recommend that to use 1 milligram per kg of methylprednisolone for ARDS, and for corticosteroid hydrocortisone for septic shock. In the RECOVER study, the famous British early results, they mentioned that The only medication that can reduce mortality, especially for critical patients, dexamethasone. So we start to use dexamethasone with any patient with respiratory symptoms. If your patient severe or critical, according to the COVID-19 definition, needs oxygen supplement with respiratory symptoms, dexamethasone 6 milligram once daily for 10 days or until discharge, which one is shortest, should be used. For pregnant, we are using prednisolone or hydrocortisone. So the only medication till now you can tell that may reduce the mortality, corticosteroid use. And we are now giving corticosteroids earlier with those patients with severe, even not intubated and not in ARDS. What about mild or moderate cases? Still, the recommendation is not to give, and it may enhance the viral protection and reduce immunity. So with mild to moderate, you should not use. Severe and critical, you can use corticosteroids. Nebulized medication, as mentioned by Dr. Tasmia, it's a aerosol generating procedure, so we should avoid, especially if we have healthcare providers without fit test in 95, or if we have no more negative pressure rooms. So we recommend that you should avoid those medications, especially if we have alternatives like meter dose inhaler. And for any adjunctive medication like nebulizers of antibiotics, inositol, cysteine, and any adjunctive therapy, we suggest that to avoid to use it's not necessary. That will increase the risk for healthcare providers. So there is no nebulized medication recommended for COVID-19, but if you have to give for special consideration, you have to give it in a negative pressure room and with PPE protection stuff or protected stuff. In SAID, some data, especially the WHO letter was coming on 18th of March. They mentioned that everyone should avoid using NSAID, especially ibuprofen. They say that some French scientists, they suggest that the use of NSAID early in the course might have negative impact on the disease outcome, especially for a few young patients who experienced very severe disease and symptoms after using NSAIDs. But after some or more data collection and more data we have, that claim is not true, and everyone can use NSAIDs, but as needed. It's not allowed to be given for anyone or as a protection. It can be used, but you should use it as the last choice. If you are using it as antibiotic, you should only use an NSAID after you fail of using paracetamol, or if there is any contraindication of paracetamol. So regarding to EMA, the European Medicine Agency, and WHO, again, they recommend not to avoid NSAID use, but use it when indicated. As I mentioned, you will start with acetaminophen, and if you have to use NSAIDs, try to use it at the lowest effective dose. And for those patients chronically using NSAIDs, they can continue their medications and there is no problem to take it. Anti-malarial drugs, we are using those medications since decades, and we know very well that hydroxychloroquine for the treatment of malaria, they are minimizing symptoms of inflammatory immune diseases such as the lupus. After in vitro, which means in labs, some studies and experiments, they approve that hydroxychloroquine can prevent the SARS-CoV-2 viruses from attaching and entering cells. That's why you can see some protocols like our MOH protocol still using hydroxychloroquine in very early phase of the disease. If the patient is mild to moderate, you can use hydroxychloroquine, but later on there is no benefit. There is no benefit of using hydroxychloroquine because it only will prevent the attachment and the entering into the cells. But according to the FDA, it's now not approved to be used for any phase, and especially for a pregnant, they are telling it's not necessary and the risk outweigh the benefit of using hydroxychloroquine. But till now, it's approved for our MOH protocol. We can tell that if the benefit is outweigh the risk, you can use it. So if you have a young patient asymptomatic or with mild symptoms but with acute prolongation, I think you should not use hydroxychloroquine because you will increase the risk for this patient while he's not in severe COVID. But if you have a cachectic patient, he's let's say with a lot of comorbidities or immunocompromised patient, and you suspect this patient will deteriorate and he's positive, you can use hydroxychloroquine to prevent or to try to treat this patient. But do we have a solid approval or evidence that hydroxychloroquine will improve those cases? No, we don't have till now. But as per the protocol, you can still use it. Like, regarding the difference between those, we think that hydroxychloroquine appears to have more potent antiviral activity. That's why it's the preferred choice. Also, it's less toxic, and there is no contraindication with those patients, or no necessary to find regular monitoring for its toxicity and G6PD test. A lot of precautions with the chloroquine you have to check, and you don't have to do it with hydroxychloroquine. So it's the preferred agent till now. Usually we are giving 800 milligram on day 1, then we are giving 400 milligram daily, which is 200 milligram BID, for 5 to 7 days. Shall we resume it for 14 days? No, because the half-life of hydroxychloroquine is very long, almost 40 days. So there is no benefit to use it for extended duration. Regarding toxicity, it's well known there is many side effects may occur with chloroquine and hydroxychloroquine, but about 90% of those patients are taking those medications will not have any side effect. So 90% of your patients will not face any side effect, but still we have 10% which is a good number. So you try to weigh the risk and benefit of using hydroxychloroquine. Till now, there is insufficient data about the efficacy. So as I mentioned, the benefit is very, very, very limited. So you cannot tell I am treating COVID. No, it's a trial for treatment, and most of the trials showed there is no benefit of using hydroxychloroquine. Right. As you know, that the QT prolongation is the main issue with hydroxychloroquine, so we have to monitor closely. This graph or figure, you can see that if the QRS is prolonged already on the right side, more than 120, so you will check the QTC. If a QTC is than 520, so you can start hydroxychloroquine without consulting cardio or without any precautions. And you have to, of course, do ECG daily. But if between 520 and 550, so you can start, but with caution. And if there is any other risk factors like drug-drug interactions or other medications that can cause QT prolongation, you have to withdraw. But if the QTC more than 550, you should not start. And for normal QRS or less than 120, if the QTC less than 470, you can start. 470 to 500, you should check drug-drug interaction and other factors that may prolong QT, and you have to withdraw. And for QT more than 500, you should not start unless you will consult cardiologist. Same also figure, but something I want you to see that you have to monitor and you have to correct magnesium and potassium, before you will start hydroxychloroquine therapy. Those are the famous side effects or major side effects: ophthalmic retinopathy, hematological, oncological, of course, hemolysis with those patients with G6PD deficiency, leukopenia, thrombocytopenia, hepatic. I think you saw a lot of patients with abnormal hepatic function test. And for those patients on insulin, severe hypoglycemia, because it will interact with insulin and it will increase the efficacy of insulin. Usually we are reducing the insulin dose by 25% when we will start hydroxychloroquine or chloroquine, and cardiovascular QT prolongation also is a major issue. Regarding the famous study was published in Lancet journal, they saw almost 90,000 patients of COVID-19, 15 patients using hydroxychloroquine, and they mentioned that the mortality was higher with those patients using hydroxychloroquine. But later on, they saw that there was a bias issue, and most of the patients were sicker who received hydroxychloroquine, and after they did the propensity score match, they find that there's no increase with mortality with hydroxychloroquine, but also there is no benefit of using it. According to pregnancy, as I mentioned, because the FDA said there is no rule, WHO and FDA, there is no rule for hydroxychloroquine, so the benefit is not there, no need to be given for the pregnancy. But by the way, it's the only medication we can give, because all other antivirals and anti-COVID, they are contraindicated for pregnancy. Favipiravir, remdesivir, levodopa, ritonavir, interferon, all of those usually or even very dangerous or contraindicated with pregnancy. Now we will talk about antivirals, remdesivir. As you can see, I mentioned it's not an ICU drug, and I will tell you why after a few seconds. This is an IV medication, novel broad-spectrum antiviral, because it may affect SARS, MERS, and even Ebola. Even it failed with Ebola, by the way, but as mentioned, it may cover. We are using loading dose to 100 milligram, then 100 milligram once daily. But there is some issues with this drug. That first thing, the vehicle, cyclodextrin, it's very toxic. If the patient has acute kidney injury, it may accumulate and cause toxicity. And there is a lot of exclusion criteria for this drug. That's why I am telling it's not an ICU drug. If you have a patient with multi-organ failure on inotropes, it's contraindicated or should be excluded as the drug of choice. If you have patient with creatine clearance less than 30, which means acute kidney injury or severe end-stage renal disease, you should exclude this one. If there is dialysis or hemofiltration, you should exclude. If there is acute liver injury, you should also exclude. Any other antiviral, you should exclude. So there is almost most of our ICU patients have some of those criteria. So till now, it's not used for ICU patients, and we are waiting for studies. Right. What about the efficacy? The perfect thing to say about remdesivir, it's likely to have some clinical benefit. Why? Because according to the study, which is the biggest study on remdesivir, more than 1,000 patients, this is a US study, by the way, remdesivir resulted in faster time to recovery, 11 with remdesivir versus 15 days with the control group, but there was no mortality effect. They did not notice any mortality effect, and it was not a statistical significant difference with mortality. And also for the Chinese study, another almost 230 patients were randomized, and they find there was no difference with the time to clinical improvement and no difference with mortality. So two studies shows there is no difference in mortality, and one study showed only that there is faster clinical improvement, and the other one showed there is no issue with the time to clinical improvement. Levodopa, ritonavir, I think everyone now knows that we should not use levodopa, ritonavir alone. As a sole therapy, we should not use it. This is anti-HIV agent. We are using for COVID-19 since March, I think. We use it alone, and then in double combination, triple combination, and all of the studies showed that leponavir, ritonavir will not affect if we are using alone. So as a sole therapy should not be used. I am receiving many phone calls and many questions. They are telling we don't have triple therapy as a whole. Can we use leponavir, ritonavir alone? As you can see here, it should not be used. This is a study. The early study was published according to this to over 200 patients, and they found there was no difference in time to clinical improvement or mortality versus placebo. And again, there was the regular care. Again, there was another study comparing triple therapy versus leponavir, ritonavir, and it showed much better outcomes with triple therapy. So, as a sole therapy, should not be used. After those data, the ISCM and the Society Critical Care of Medicine, Surviving Sepsis Campaign, all of those agencies and associations suggest against the routine use of leponavir, ritonavir for critically ill patients as a sole therapy. Favipiravir, our new agent, we have it now in Saudi Arabia. This is our RNA polymerase inhibitor. It's from Japan. Asian countries only availability. It's not available in US or in Europe. I think now some European countries start to use it. Unfortunately, 2 days ago there was a small study with very unpleasant results. They mentioned it's not so hopeful drug, but in this small study, it was used for patients with auto saturation more than 93%. So they are not severe or critical patients, but the results was okay, faster rate of viral clearance and more frequent radiographic improvement. So it was good, but when we use it with mild patients. But according to the MOH protocol and our cluster 1 protocol, we are using remdesivir now for critically ill patients because it's the only therapy available for critically ill patients. But we have some limitations. According to the data, we don't know a lot about side effects. We don't know about dosage adjustment with liver impairment, with renal impairment. And also regarding to the pregnancy, it's absolutely contraindicated. However, even for those male, they must avoid intercourse for at least 4 weeks after using favipiravir. So it's very teratogenic. So we should use it with the pregnancy. We should not use it with pregnancy, and even for male, they have to avoid intercourse. Triple therapy, as I mentioned, we used interferon, ribavirin, leponavir, ritonavir, triple therapy versus leponavir, ritonavir, and the result was that rapid times to negative COVID-19 PCR tests and the clinical improvement was better. Hospital discharge was earlier. So a lot of positive results with triple therapy. But again, a lot of side effects, inappropriate or inspecific doses or dosing, and only the result came with those patients within 7 days of symptoms. So we are using those with severe COVID-19, not for critical COVID-19 patients. So if we catch the patient early and we give him a triple therapy, he was a good candidate. So we are seeing a good results. But late, if there is no indication and no recommendation to use a triple therapy more than 7 days. Some are using double therapy more than 7 days till 14 days, but in our KSMC or protocol, we are using favipiravir if more than 7 days, but less than 7 days, we are using a triple therapy. Also, as I mentioned, teratogenic agent, and usually should not be used with pregnant women. Regarding convalescent plasma, it's a hopeful, inshallah, and we hope it will come with positive results. We have 2 clinical trials now ongoing in KSMC. At KSMC, we are trying to use this convalescent plasma. We are taking some plasma from recovered patients. We are measuring the titer of IgG. If it's high enough, There is specific range. If it's high enough, we are taking the plasma and we are giving to critical patients. We have good results till now with, or good experience with very few cases. And even the data available regarding to this, it's very limited. Unfortunately, it was not successful with MERS-CoV. They use it over almost 200 patients, and it was not effective, but we hope it's effective for COVID-19. Limitation, a lot of logistic issues. You have to arrange the test, you have to arrange the donor, the proper time. A lot of issues you should arrange if you will use convalescent plasma. So this is the limitation we have. Interleukin-6 pathway inhibitor like tocilizumab. This is not a COVID-19 medication, but it will decrease the complications of COVID-19, like cytokine release syndrome. So we are using those interleukin-6 inhibitors after specific criteria. If there is a cytokine storm or a lot of indicators of cytokine storm, we are using tocilizumab. We are giving 2 doses. Usually up to 3 or 4 doses can be given, but for the indication of COVID-19, we are giving maximum two doses, 400 to 800 as IV infusion. And the in-between interval is 12 hours. There is other like cetuximab, but we don't have it here in Saudi Arabia. Supplements, vitamin D, vitamin C, we have also zinc. A lot of supplements was mentioned to be used. Some of those medications will help for immunity. Others we are using because we have some experience, like vitamin D with those patients in ARDS. 2 trials showed that it may decrease the length of stay in ICU, and it may shorten the duration of mechanical ventilation. One of them, it was up to 24%, and this one up to 18%. But we don't know about the relation of vitamin C with COVID. We don't know. You can see now we are using suppressive agents with the critical patients, not using or immune supplements, vitamin. So it's very controversial, and but for ARDS there was a good result, but not for COVID-19 till now. Our usual consumption per day, it's around 0.1 to 0.2 gram per day, but for critically ill patients, 1 to 6 gram per day. So it's almost 10 times to 60 times higher than the usual consumption. So there is a lot of controversy, and we are not using right now, but we need to check if we need to give suppressive therapy or something to enhance immunity. And we need to check at which level of or which phase of the disease we want these drugs to be added. Like, I will go to the protocol very fast because I know we have no time. Okay, as I mentioned, we have COVID-19 for cluster 1 protocol. We have suspected, we are dealing as any ICU patient, but we have those with confirmed. We will start anticoagulation. As you know, we have a major issue with coagulopathy for those with COVID-19, so we are suspecting higher or hyper coagulation. So we are giving high doses of DVT prophylaxis. Sometimes we are giving treatment. First thing, you have to check the bleeding risk. If there is no bleeding risk, that the platelet count is more than 25, no active bleeding, no hit, any of those issues that contraindicate the use of enoxaparin or heparin, you should rule out. If it's okay, you can start with enoxaparin according to the weight. If D dimer is normal or less than 1000 or less than 1 mic per ml, according to your unit, we are using 30 milligram BID. If the weight is normal or less than 100, if the weight between 100 to 150, we are increasing the dose to 40 milligram BID, and so on. If there is acute renal impairment, acute kidney injury, or acute or end-stage renal disease, and creatine clearance is than 29, we are using heparin instead of enoxaparin. Of course, as I mentioned, if the patient will use hydroxychloroquine, you have to check toxicity. If he will use or she will use chloroquine, you have to check or send to G6PD screening. And in early phases, we are giving vitamin D and thiamine to the patient. If the patient will use also chloroquine or hydroxychloroquine, we have to optimize electrolytes. I think this is same what I mentioned. Regarding pneumonia, we are treating CAP for all the patients came to the ICU. Coming to the ICU, we are treating community-acquired pneumonia. And this slide or this page, you will have all doses. Any medication you might use in this protocol, you will have the doses and the duration almost for all. Now we have the DVT prophylaxis. This is the last thing in my slides, but I have to show you. Yes. Dr. Ahmed.
Dr. Bashir?
Yes, you can see the
Yeah, we can see, but please
appendix.
have
Okay.
limited time. So.
خلاص. This is the last slide.
Okay.
Okay, if you have confirmed cases, as I mentioned, there is no risk for bleeding. If there's, you will go to D-dimer. If D-dimer less than 1 or equal 1, you will check creatinine clearance or kidney function. Normal, it's preferred to use enoxaparin. Enoxaparin according to the weight, but if it's low, less than 29, or your patient anuric or in the stage, you will use heparin. Type. If there is risk of bleeding, you will use intermittent pneumatic compression until you can use pharmacological agent. Right. If there is no risk of bleeding but D-dimer more than 1, we are using higher dose of prophylaxis with normal kidney function or good kidney function. We are using enoxaparin 40 milligram BID for normal weight. If weight between 100 to 150, we will use 80 milligram BID as a prophylaxis, this one. And we are currently doing, if the D-dimer more than 3,000 or more than 3 in our unit, we are using heparin infusion or enoxaparin treatment. We are using full dose. Okay. Thank you very much. Dr. Ahmed.
Thank you, Dr. Bashir, for your lecture. So now we will move to the last lecture for the next 20 minutes. It will be about shock and fluid management.
والله I cannot hear you. نعم.
Dr. Bashir?
Doctor? نعم. Yes, I can hear you now.
Okay. I think we have there is one question actually, plasma therapy, how it will work as viremia curve flattening after 10 days.
Yes. Well, till now we don't have data about late use. Convalescent plasma, only one of our exclusion criteria, more than 7 days. As you mentioned, more than 10 days, we are not using convalescent plasma. One of the exclusion criteria, if more than 7 days of the onset of symptoms.
Okay.
Pulse steroid in ARDS we are not using. We are using 1 milligram, 2 milligram per kg. Pulse steroids we are not using for ARDS. Remdesivir can be used from mild to critical patients. Any stage we can use remdesivir. Very limited side effect, but in our protocol, in Moachi protocol, they mentioned only for critically ill patients. But it's now, till now, unfortunately, it's not available except for clinical trials in some hospitals like National Guard and King Faisal. But in Moachi, we still do not have it.
Okay, thank you, Dr. Bashir.
Thank you, thank you. Thank you all. يعطيكم العافية.
Right. So for the next 20 minutes, we will discuss about shock and fluid management in the COVID. So we'll try to stick in the time because we are at the end of this course for the first day. So here we will, our objective actually to be around the fluid responsiveness and definition of shock, pathophysiology of shocks and types of shock, clinical manifestation of shocks, what some therapeutic modalities of shock. So here we will see about the fluid resuscitation. Actually, the fluid resuscitation, it increased the mean systemic blood pressure, which it can increase diffusion of oxygen in the shock status. But if you give more fluids, actually, more resuscitation, it can cause more hemodilatation. It will affect at the end result with decreased cardiac output and increased capillary pressure, which it will cause more edema, and it will be progressive with this value, more vascular injury it will cause and at this stage. So there is a relation between the fluid loading and the complication. It was done in high surgery, but actually we can apply it also in ICU because it's the same idea. If the patient is under resuscitation, there will be more complication and mortality. But if the patient in eovolemic, so they are in better situation, less complication and less mortality. While if the patient over resuscitation, it will increase complication and mortality at the same time. So what are the consequences of the general edema? Because if you have generalized edema, so what will have the consequence? So the oxygenation will be decreased, gases exchange will be less. There is impaired, if the patient has wound, it will be the healing is very difficult actually. It may induce also pressure ulcers, and also it can increase some brain edema, increase the gut dysfunction, which it will decrease the tolerance of feeding. Sometimes can increase the intra-abdominal pressure, which it can cause compartment syndrome. And this compartment syndrome, increase the intra-abdominal pressure, can cause pre-renal azotemia, which it can cause also renal failure, and decrease the venous retain, can cause also shock status. So myocardial dysfunction also can cause, as we mentioned, the risk of decubit acid, and impaired mobilization, it will be difficult. So now we will go for what is the best fluid resuscitation we can use. Actually, there is the trial. There's two trials actually. The first one was published in 2012, and the second one it was published in 2018 in Main New England Journal. So in overall, actually, the mortality it's better. The mortality and the renal, respiratory, who has major hemorrhage or infection, they are beyond going, as this odd ratio is 1. So all this area, it's going with the balanced crystalloid. Balanced crystalloid or buffered fluids like Ringer lactate or Hartmann fluids. So it's preferred. Except actually, it's shown in the SMART trial in the patient who has actually the cardiac issue, or the patient it was in the traumatic brain injury in the previous one, so it's beyond the saline better. Why is balanced crystalloid is better? Because this chloride, this is one of the explanation. This chloride, this renal injury it will be. So how could we evaluate the fluids responsiveness? So the fluid responsiveness, there is a lot of methods we can assist the patient clinically in the ICU. So we can assist the patient through multiple issues. So we will just select some of them for discussion. Does this patient need the fluid? So I can assist just to bring the ultrasound and assist the IVC. You can put it subcostal view. In the subcostal, you can see how is the IVC collapsibility. or there is no collapse as distented, so you can help in some volume status. So this is called a static assessment, not dynamic. Lactate again, so you will take the blood gas or the serum lactate, you will check, and if it is more than 2, as a bare definition of shock, it should be increased. So it will be high the lactate. Then you will assess how the lactate is decreasing, like you give the patient fluid, so this patient fluid responsiveness and the lactate will go down or it will not be affected. And the other issue, the fluid challenges, there is two methods, either to give 500 ml and see how is the blood pressure improving, or you can give called minimal challenging. You can give 100 ml saline and you can check immediately the blood pressure. If you have invasive methods of monitoring, like you have called PICO or arterial line, and you can see how it will be. The other, through the mechanical ventilators, we will not discuss it here because it's beyond this course. The stroke volume variation also, this is advanced, like you can see through the ECHO or BICO or E1000. Pulse pressure variation also the same. Pressure leg raising, it's we will see it now how it will be done, and CVP. So the positive brush, the passive leg raising, actually the patient is sitting in 45 degree. After that, you will keep the patient in the flat. You will raise the body, the legs up. Should be this one, the angle around 145. Because if you keep it more straight, or more, the angle is 90 degree or 100 degree, there will be an obstruction, so the blood will not go back from the legs to the heart. So this is around the 300 to 500 ml, it will be back to the heart. So if the blood pressure is improving, so it's and the cardiac output will be improved. So this is called passive leg raising. But here the most important, you should not touch the patient. It should be without touching the patient, because if you touch the patient, can cause sympathetic stimulation and can give false positive. The other issue, once you will finish, you will see the change in blood pressure. You will return the patient to the same position where he was, and it should be the blood pressure back to the what it was in this stage, in this volume. So this is how we can differentiate between fluid responsiveness and not responsive by passive raising, leg raising. The other, as we said, what is called the inferior vena cava assessment. So the ultrasound, you will assess the inferior vena cava. You will see how is the collapse rate. If you see here, this is during inspiration. So once you are taking inspiration with mechanical ventilation, how it will be the venous retain affecting. So here it will be collapsing actually, and during expiration it will be expand. Because if you take more inspiration, it will cause more negative pressure, so the blood go more, so it can exaggerate the negativity, or it can be like you are sucking the blood from the abdomen, so the IVC will be collapsed. So if there is a difference between, you will measure at end expiration, during the expiration and the respiration, the maximum diameter, roughly if it is around more than 50% the difference, it's going with the fluid responsiveness. So here an example, this is a 72 years old man, obese, diabetic, hypertension. He has a history of ischemic heart disease. He was admitted also as a case of septic shock. Intubated, and because of respiratory distress and developing ARDS, the patient has developing hypotension and decreased level of consciousness. So if we go to the assessment, we found this patient has high lactate, blood pressure is low, fluid challenges was giving, still the blood pressure is low, not improving. Pulse variation, actually, it is still not significant, 11. It's not that much significant, actually. And when they do passive leg raising, it's the blood pressure almost the same, not significantly improving. Inferior vena cava assessment was done, the ultrasound showing there is no changing, or there is no collapsing vein. So this is going with what is called non-fluid responsive shock. So if you give fluids here, we are not expecting the patient will improve. You may harm the patient more and more, especially who has acute respiratory distress syndrome. You have to be conservative in the fluids, because if you give more fluids, the mortality will be high, because more fluid, more oxygen requirement. These who are this, usually they have high oxygen requirement, and you will find some patients you need a FiO2 of 100% for them. So imagine you are putting the patient in 100% FiO2, and you are giving fluids, making more pulmonary edema, and so it will be difficult. So if you go to the hemodynamical instability, why the patient has hemodynamic instability? Is it secondary to the vasopressia, or hypovolemia, or RV failure, or COVID-19 myocarditis? So this is the, you have to keep in your mind these causes, because especially in the initial presentation, usually in the initial presentation, they are not presenting secondary to the septic shock. Either they have, like, for example, they have intubated and they have high dose, so it can cause vasopressia, or it can be associated in the septic shock in the later on, not in the early stages actually, or the patient has hypovolemic because he's not drinking, not eating properly, he's febrile, losing fluids, or the patient developed myocarditis. It can be also associated with sometimes acute coronary syndrome, heart failure, which can be another causes. Right-sided heart failure, we know some patients they have RV failure, secondary to COVID-19. So what are the definition of shocks? This is very important to know what is the definition of shock. So the shock, just keep in your mind, there is decrease, it's failure of deliver of adequate amount of blood for the tissues. So how we can see it by numbers? Systolic blood pressure less than 90, or decrease the systolic blood pressure more than 40 from the baseline, or MAB less than 65. In addition to that, you have to find some evidence of hypoperfusion. So here we can say the hypoperfusion can be the lactate more than 2. It can be sign of hypoperfusion like acute kidney injury, decreased level of consciousness. So if you go to the what's called the quick SOFA, you will find 3 important items. This is respiratory rate is high, and systolic blood pressure is 100, and also altered level of consciousness. So here the pathophysiology also, how it will be. Usually, as you find in the first 4 to 7 days, as Dr. Mahdi he presented initially, they have some flu symptoms, and usually they are recovering spontaneously because they have mild cases. But in the mid stage up to mid period of the COVID course, 4 to 7 days, they have pneumonia with evidence of hypoxemia. This is usually with more cytokines, or it can it's starting the pneumonia, the cytokines to be developed, but the viremia, it will go down. So here, that's why now they came with evidence of dextroids. It can be, dexamethasone, or prednisone, steroids. It can be helpful in this stage for hypoxemic patients. Later, in the advanced stage, usually they can develop myocardiomyopathy, little evidence of hypovolemia, as second, even the strokes of myocardial failure. So as we mentioned here, shock, it's systolic blood pressure less than 90, MAP less than 65, or decrease the systolic blood pressure more than 40 from the baseline, like who's the patient, usually his blood pressure 150, and now he's came with his blood pressure 100. So this is considered as a shock. In addition to that, hypoperfusion evidence, high lactate more than 2. So what are the factors affecting the MAP? So systolic volume, stroke volume, multiply heart rate, multiply systemic vascular resistance, and CVP. So here what we it's the stroke volume, how we can calculate or what are the factors affecting the stroke volume: preload, contractility, afterload. So the preload, fluid is low, decreasing. Contractility, myocarditis, heart failure, it will decrease the MAP. Afterload, also it can affect it. So the heart rate, the patient who has tachycardia and he has bradycardia or he has severe bradycardia, they will have also decrease. It will be decreasing the mean arterial blood pressure. Even the patient has, like example, inflammatory response. He has vasodilatation, like he has septic shock, has anaphylactic shock. They will develop decreasing level, sorry, decreasing what's called the mean arterial blood pressure. So shock, by definition, it's continuous persistence of hypovolemia, of hypotension. In addition, we are giving some challenging of fluid with high lactate. So if the patient and requiring vasopressor to maintain the blood pressure, the mean arterial blood pressure more than 65. So if you need just vasopressor to be added in addition to the hypotension with normal lactate, this is not the definition of shock. Even if you're a definition of shock, you have to have some evidence of hypoperfusion with high lactate. So this is very important to differentiate between this is the patient in shock or no, because high lactate is poor prognostic factor, or poor, it can increase the mortality. So if you go to this question, actually, where is which of the following patient in shock status actually? So here, this patient, 30 years, all of them, they are hypotension. These two patients, they required inotropic vasopressors, but the difference, this patient has high lactate, so the high lactate is going with definition of shock. So if you go to the pathophysiology, you have to know, it's important to assess in the shock, how is the capacity, so the fluid status is important, the pump status is important, or the systemic vascular resistance, it's important. So any one of them, like if the patient is inadequate volume, or the patient has pump failure, this can cause hypotension or dilated circulation, as we mentioned, like inflammatory, we discussed now. So these patients who's the normal, this is the patient hypovolemic, this is the patient has distributive shocks, this is the patient has heart failure. Heart failure, you will see the tank is full. Distributive, may the tank is partially empty or it's normal. Hypovolemic, like the patient who has hemorrhagic or has burned, dehydrated, not adequate intake. So what the types of shocks? We can divide it into two groups, recessive or distributive. Recessive mean decreased cardiac output. Keep it in your mind. Recessive, low cardiac output. Distributive, high cardiac output. High cardiac output, this is either it can be, because it's a compensation. If you have high cardiac output, you have systemic vascular resistance dilated, so the heart is pumping too much to compensate the vasodilatation as much as they can. So, but if you have recessive, like the patient hypovolemic, cardiogenic, or obstructive, the heart is are not able to pump properly, but because the stroke volume is low, but at the same time, the systemic vascular resistance will be high. Like the patient, he is not eating well, he's dehydrated, or he has diarrhea, he has hemorrhagic shock. So these people, you will find the heart is not pumping, there is the stroke volume is low, so the pump, there is evidence of heart failure, there is evidence of low cardiac output, I mean, but at the same time, you will find there is compensation with systemic vascular resistance high. So all the peripheral vessels, it will be constricted to try to compensate this hypotension. But in distributive, you will find the patient septic, anaphylactic, so it will be vasodilatation, but at the same time, cardiogenic, the cardiac pump is high. So if you assess this patient, if you go to this is patient clinically, he's warm, dry periphery, and he's tachycardia, bounding pulse, and he has high pump, low vascular resistance, low capacity. So what we think about this case? High pump, it's going with recessive, or what is the other we said? Can someone remind us? or distributive? So you can write in the chat room, please. So this is what is called. It is resistive or distributive. Okay, it's distributive. Excellent. Because as we mentioned, there is high pump, and low vascular resistance is there. So what's the other example? We said septic shock, anaphylactic neurogenic Addison adrenal disease. So the other case, the patient is cold, tachycardia, and the vein it's like empty. The patient has low pump, and he has high vascular resistance and low volume capacity in tank. So what is this? This distributive or it's resistive? So excellent, it's resistive. So resistive, what is it? Is it hypovolemic or it is cardiogenic? Because the tank looks like empty. So it's hypovolemic, excellent. So we have to look what are, or it can be also the obstruction like BE. So this is the other differential. Here, the other scenario, but it's the full, the tank is full. So going with cardiogenic shock. So now we will go again for the surviving sepsis campaign guidelines for the management of the COVID-19. So what they are recommended here, we will take this slides from this guidelines because almost we are about to finish. So what are the types of fluid we need to give as resuscitation? If you want to resuscitate with the fluids, we will select crystalloid over than colloid because the crystalloid, like normal saline, ringer lactate, is over the colloid. The colloid is more expensive, but the outcome it's the same. But the buffer balanced crystalloid, like ringer lactate, as we mentioned, it's over unbalanced like normal saline. So if you want to select someone, select please balanced crystalloid is better. But don't use what is called the starch or hydroxymethyl starch. Don't use it, or history, some hospital they are calling. Don't use gelatin. Don't use dextran. This is all can cause more renal impairment. But keep in your mind, as we mentioned, conservative over liberal. So be conservative with the fluids. Not anyone to give more fluids. At the end, you will be stuck with the more mortality and more comorbidities, more factors or poor prognostic factor it will be. So we suggest if you want to add vasopressors, the most important or the first line of that, it will be noradrenaline. So the first vasopressor, it will be number one, noradrenaline. Next, if you want to add, you will add vasopressin. Don't start with dopamine, please, because dopamine is it's increasing the mortality and more arrhythmogenic. So it's not preferable at all to be started at the first line. So the first line is noradrenaline. Second line is vasopressin. Can we start the peripheral initially? Yes, there is some literature. You can start dopamine, be considered as more safe, but you can use also NORAD up to 0.1 or 0.08 for 6 hours almost. It can be the safest, but you have to have good vein, good cannula, because any extravasation can cause local ischemia. So it's better to be the central line as soon as possible. So keep in your mind, not all the types of shock, it's hypovolemic or septic shock. We found a lot of patients, they have underlying their cardiac disease, or once you have ultrasound, echo probe, you can just put it in the ultrasound. It's available most of the ICUs now. Just once you will put the probe of the echo, you will find a lot of extra information you can get it. Either they have valve disease, like yesterday we have one patient, just once we put the probe, we found he has bicuspid valve, he has severe tricuspid, severe mitral regurg. So just utilize that, what you have, take the opinion from the others. Not all the patients are the same patient, so personalize your patient accordingly. So if this patient, he is hypotensive, he has high lactate, you give him some fluids, but the patient's blood pressure is still hypotensive. So what's the next? Can you write in the chat? You will give dopamine, adrenaline, noradrenaline, or vasopressin. What is the first line it will be? So NORAD is the best place. So before there is a question regarding dopamine. Dopamine actually for the hypotension as the first line is not preferable because if once you start dopamine, especially in the small dose, it's more vasodilator. Yes, it will improve the contractility, but it's more vasodilator and it can increase hypotension. So maybe you can start with NORAD, then you will add dopamine later if there is evidence of cardiogenic shock. So take home message, definition of shock, evidence of hypovolemia with evidence of hypoperfusion with high lactate, in addition to, as we mentioned, MAP less than 65 or systolic blood pressure less than 90 or decreasing more than 40, and requirement of vasopressors. Types of shock, most important two types, resistive, distributive. Resistive is low cardiac output, distributive, high cardiac output. Not all the types of shocks are fluid responsiveness. Fluid is a drug. 50% of the patient ICU, they need the fluid, 50% they don't need the fluid. So you have to be careful to select your patient and to assess properly. First line of vasopressor, as we mentioned, NORAD, then vasopressin. The recommended IV fluids are balanced crystalloid or buffered fluids like ringer lactate, as we mentioned. Thank you so much. Sorry to be late for the lecture, and sorry to take more time from you. So if you have any question, we can answer some question. Okay, thank you. Thank you, everybody. Thank you for your precious time. Regarding the ringer lactate dose, usually you can start with 200 to 500 ml and reassess the blood pressure, how it will be. Some literatures, the liberal fluid resuscitation, they are saying up to 30 ml per kg as boluses to be assessed. So thank you, everybody, and see you tomorrow, inshallah, at 8:30 with the second day. Yeah. Thank you. Assalamu alaikum.